Good evening, everyone. Today we are in Uttar Pradesh, the land where we have Ganga, Jamuna, Saraswati, and we have the Triveni Sangam at Allahabad. A wonderful place and a wonderful language which we speak, and we have with us today illustrious and superb endoscopists, fertility consultants joining us, and it's going to be a great session. We are going to have 3 lectures. Along with that, we have wonderful video sessions for you. This is a very unique program in the land of Uttar Pradesh, and the Uttar Pradesh chapter of IAGE, which was installed in 2018 by the then President Dr. Reshma Pai when she was at the helm of affairs of IAGE. And the chairperson is Dr. Narendra Malhotra sir, and the secretary is Dr. Amit Tandon. So without wasting much of your time, we would like to go, and I want to call now Dr. Jaideep Malhotra madam. She is going to deliver her welcome speech, an inaugural speech, and inspire this UP chapter of IAGE webinar. Dr. Jaideep Malhotra madam is the Managing Director of Rainbow Hospital, Professor of Dubrovnik International University, Croatia. We know that she is the President of FOXI, ISAR, IMS, SAFOMS, ISPAT, Aspire, and has got contributions to various articles in international and national journals and her publications. A very warm human being, kind-hearted. Madam, welcome, and I request you to please inspire all of us with your 2 lines. Madam, please unmute.
Yeah, thank you, Niranjan, and a very good evening to all of you, especially to our chief guest, Dr. Raj Baweja, who's been a mentor, and Dr. Chandravati. Heartiest welcome to both of you. And to all of you who are there in this wonderful program, which has been very ably organized by a very able person whom I have really, started to admire very much in the last few months, is Niranjan Chavan. He has amazingly, organized such beautiful programs, whether it is for IAG, for FOXI, and many more, and with wonderful faculty. UP chapter of IAG, though it's a very young chapter, but the people who belong to this chapter are pioneers in this field. And I am so happy to see quite a few of them today. Nutan Jain has been a phenomena all over the world. Amit is doing wonderful work, as far as laparoscopy is concerned. And Naren has been one of the first few to start endoscopic surgery. Needless to say, I have been part and parcel of this chapter, and also I would say that we were the first few, in fact, in the national chapter also. So it is really nice to see that this is becoming active. I have seen Neelam Mishra also. Neelam Mishra is also doing a great job. And a lot of our youngsters are doing amazing work, which are there. Niranjan, I'm sure they're going to be there with you in your discussions, and they're going to showcase some wonderful work by them. So it is fantastic. And I would say that our guests of honor, again, very eminent people, Ragini Agarwal, Anupam, and Kiran Pandey. Thank you so much for giving me this opportunity to be able to see, the good work being done by all of you. And keep the good work going. All the best. I'm sure this is going to be a great deliberation.
Yes, madam. Thank you, madam, for your encouraging words. And it was so nice of you to come today and be a part of this program. We are very honored and privileged. You are amongst us. And that's what we decided to go to various areas, various zones, various cities, various states, and there we find a beautiful the masala and the mix of videos along with wonderful lectures. So thank you so much, madam, and please be there. I would like to now call upon our chief guest, none other than Dr. Raj Baveja, madam. She's an MBBS MS gold medalist, a PhD by Allahabad University. Presently, she is working as emeritus professor, worked as professor and head officer in ICMR and Motilal Nehru Medical College, Allahabad for 18 years. Madam, thank you so much for being there. The next, I would like to invite now Dr. Chandravati, madam. Who doesn't know Chandravati? Madam Chandravati, madam, I was the first, my first AICOG was in Lucknow. Very few people know in 1999. That time you were the professor and now you are the emeritus professor. You are the director of Krishna Medical Center, Lucknow, managing trustee of the Krishna Education Foundation. And we also remember this year, before the corona pandemic started, Chandravati madam, we had the AICOG. What a wonderful event you and Preeti Kumar have managed. Thank you, madam. You got wonderful awards. I request you to please speak one line for us today. Please unmute. Yes, madam, please unmute your, you have to press a button which is there and the below. Yes.
Yes, I got it.
Yes, madam. I request you to please say.
Niranjan, thank you so much. Thank you so much. You gave me the information and I got the link also very nicely today. And I'm obliged to all the people who have come over here, especially Narendra Malhotra, Jaideep, and Dr. Chandravati, whom I know for such a long time. And they have been excellent friends with me. And I remember when both the Malhotras, the two little children, we had been to Canada at a conference, and how well they looked after me. And today they have become in the level of people to be remembered forever in the line of obstetrics and gynecology. These people have given people have been able to recognize Uttar Pradesh only because of Malhotras at the office of Foxy. Although I also started the branch at Allahabad. When I came over here, till that time, there was no academic sessions at all. I had to establish the gynecology and Dr. Chandravati, I worked already for such a long time. We are great friends, and she has been helping me right and left. Moreover, all those people have joined over here. Anupam is also here. I've seen him as a child. I'm really obliged to everybody over here who have given me a chance to speak at least a line over here. Thank you so much. And I also request one thing more. Why don't you start small school, especially at Agra or anywhere else, like colleges or institution which can teach the young people in endoscopy. I remember Chandravati and myself, I think we have done lots and lots of laparoscopy sterilizations at a time when it was needed most in a very bad circumstances. And we had high incidence of complications. Please, let us all go in for laparoscopy and learn properly, especially for the students and the people who are coming up now. Thank you so much for giving me a time to talk. Thank you.
Thank you, Dr. Raj. It's an honor that you're there now. I call upon Dr. Chandravati, madam, to please inspire us with your 2 lines. Thank you, madam.
Thank you, Niranjan, for having us here. And it is a pleasure to see Rajji. When Rajji is there, we stand nowhere. But still in front of her, I have some words to say. First thing, my blessings are with you. And it's always pleasure to see youngsters working so hard and reaching to such heights. And I'm sure that what you came as a young star here, you will be a full star since, within few months or somewhere. I bless you with all the good wishes and everything. It is wonderful to see this beautiful faculty today. And I'll be sitting throughout this your whole session for 2 hours. because so many cases, interesting cases, presentations are
Yes.
also there. So I have gone through the whole program and I think I'm going to thoroughly enjoy it. Niranjan,
Yes,
I
madam.
wish you to organize more such webinars and involve the good faculty, and it is a pleasure to see wonderful videos and wonderful surgery done by youngsters, and they have become such an expertise. Myself and Raji used to do a lots of lap surgery in form of sterilization, and we didn't go beyond that because at that time the lap surgery wasn't a very uh, advanced way of doing surgery. But now times we have learned and we are doing some surgeries, and maybe we would be seeing more and more advanced lap surgery in times to come. Wish you all the luck, all the success, everything to you and your Komal, and
Yes, madam.
wish you health in your family. Thank you.
Thank you, madam. Thank you for your kind words and blessings. Thank you so much. Now, Sana, I request you to please showcase the guest of honors. We have Dr. Ragini Agarwal, Madam Vice President of Foxy, the Iron Lady from Haryana. Lot of work which she has done in adolescent, in cosmetic gynecology, in high-risk obstetrics. She has been the president-elect of Aesthetic and Regenerative Society, president founder of Haryana Association of Obstetricians and Gynecologists. A very dynamic person, in short. Thank you, madam, to be with us. Next, Dr. Anupam Gupta, my elder brother. I know him since probably 25, 30 years now. Always we meet on professional conferences, and even he had organized a wonderful conference, a UA Foxy in Kashmir. Till then, now I don't recollect any vice president might have arranged a Foxy conference in Kashmir, and that's what he did during the tenure of Dr. Prakash Trivedi. Welcome, Dr. Anupam. You have been the past president of Agra, chairman of UP chapter, ISAR. Thank you so much for joining today. Please participate, and do be there for the scientific expert sessions. Dr. Kiran Pandey, madam. She is also a wonderful lady, a professor and head, and the Department of Kanpur, GSVM. She has got a lot of laurels, lot of state awards. She was also the president of Kanpur Society, president of IMA. Welcome, madam, to this wonderful place. I request you to please have one sentence each one of you so that we can go ahead fast to the chairpersons because audience are waiting. Thank you. Please unmute. Anupam ji, please unmute. Yes, thank you.
Hi everyone. It's really to have two of the godmothers, my godmothers, Dr. Chandravati ma'am and Raj Babuja ma'am, and of course Dr. Jaideep Malhotra and Naren Bhai, who have always been a guiding force to me. My seniors, Dr. Nita ji, my friend Anurita, Dr. Aati, and my two younger brothers, Niranjan and Amit. Me and Amit have grown together in Agra, and me and Niranjan have grown together in Foxy. It is indeed a pleasure having all of you here, all these senior people and the and I imagine all the best to my dear Amit to have more and more followers in future. Looking forward to more and more seminars and more webinars till we meet post Corona again. Wishing you all the best, Niranjan, and I would like the other people to say a few words.
Yeah, thank you so much. I think when Dr. Kiran will join, she will say a few words. Is she there?
I don't think. You can start the slide.
Yes. Now we will go ahead with the. We will go with the scientific session. Now I would request to show the chairpersons, and I will hand over the mic to Dr. Neelam Owari. She is presently in Varanasi. She is also the medical director of New Life Hospital, secretary of Varanasi Menopause Society, vice chairperson of ISAR UP, vice president, past president of VOGS, Dr. Neelam Owari. Welcome, madam. Next. Well, I would like to invite now Dr. Nisha Singh. She is a professor at KJ Medical University in Lucknow. She has also done an oncology fellowship and observership at Stanford, Bart's Cancer Institute, Treasurer of Association of Gynae Oncologists of India, Joint Secretary, Asia Oceania. She has got many awards to her credit and has published many publications, chapters, guest lectures. Welcome, Dr. Nisha. And I would also like now to invite Dr. Surita Karim. She is from Gorakhpur. She was the president of Gorakhpur Society, president of Innerville Club Gorakhpur, secretary of the Gorakhpur Obstetric Gynec Society. She's trained in laparoscopy and hysteroscopy in 98 from Frankfurt, Germany. So welcome all three of you. Please go ahead and start introducing your lecturer speakers. We have the first speaker, Dr. Nutan Jain, madam. Then we have Dr. Amit Tandon and then Narendra Malhotra sir will join once his meeting is over. I hand over the mic to Dr. Neelam Mohari. You can start the first lecture. Thank you, madam.
Go screen sharing.
Yes, Dr. Neelam, you can introduce Dr. Nutan Jain, madam.
Yeah, it's really a great pleasure to be here in UP IAGE webinar, and thanks Dr. Chavan for inviting me here, and it's really a great pleasure. And it's my privilege to introduce a person of great eminence, that is Dr. Nutan Jain. She represents UP in a great way. She is director of Vardhaman Infertility Endoscopy Center, Muzaffarnagar, and she has so many credits to her. She is elected board member of International Society of Gynecological Endoscopy and member of Governing Council of ICMR, and she has organized so many workshops and conferences in laparoscopy, and she had live telesurgery relay of laparoscopic surgery to AAGL 46th Annual Global Congress in Washington, D.C., USA on 16th November 2017. And she is nominated for AAGL Board of Directors in 2019, and she is author of 8 textbooks of laparoscopic surgery, which are translated in Spanish and Chinese and are very popular worldwide. And she conducts regular training courses and fellowships and diploma courses at her center for endoscopy. So I invite Dr. Nutan Jain for her talk. Dr. Nutan Jain, please.
Yeah. Thank you, Dr. Neelam, for such kind words. It's my great pleasure to be a part of this wonderful initiative by Dr. Niranjan, Dr. Narendra Malhotra, and to have the eminent presence of Dr. Raj Baveja and Dr. Chandravati and all the guests of honors. So I just take an opportunity to thank you and introduce my new hospital. So these are the new operation theaters we have come up with, and this is the gynae OPD. Initially we thought they are too big, but now in the event of corona epidemic, they look like to be serving the purpose of social distancing. So the topic given to me today is to talk about the pelvic floor repair, and I thought of introducing some newer, they are not absolutely new, but the applications which we are using could be a little different from just all over the routine. So all of us know that laparoscopy is giving wonders in the management of prolapse. And
share your PPT on the screen.
विशांत शेयर नहीं हो रहा पीपीटी पीपीटी शेयर करो Yeah, just a moment. Hospital की picture नहीं है. Yeah, do you have it now?
Yeah, yes.
Sure. So, greetings from our new center, and this is the theatre complex, and this is my gynae theatre and not a garden, and my daughter-in-law operating in the other one. And these are the like OPD ward, which I said we thought they are too big, but in the corona epidemic they are working for social distancing. So today we shall be discussing about some newer applications of pelvic floor repair. As all of us know, Prolapse is a common gynecological problem and has wonderful results with laparoscopic management in preserving fertility and giving good anatomical outcomes. So the prolapse repair could be with the use of mesh, without the use of mesh, or the combination techniques using the site-specific suturing and augmenting the repair with the use of mesh. So gynecologist has a handful of options that could be a plan A and plan B. So the factors which decide the type of surgery to be done are dependent on the age of the patient, desire for future fertility, overall muscle tone, associated SUI, and the assessment of anterior posterior compartment, or whether the patient needs hysterectomy at the same time or not. So the surgery has to be tailor-made according to each patient, and we have to use several techniques in one single patient, keeping upon the factors which we have to correct. So the site-specific repair means that the prolapse is sort of a hernia. So from where the tissue has broken away from the attachment, it has to be repaired back. It can be done only by site-specific repair, meaning thereby that suturing the defects. Or otherwise, as we do the laparoscopic pectopexy, we do a combination of first suturing the pubocervical fascia and then strengthening it with the use of mesh. So here we have a young patient who had a normal delivery 5 years back. She had a grade 3 UB prolapse and now she wants a hysteroplexy. So here this is the outside picture and this is the inside picture. So first we open up the utrovesical fold of peritoneum and we open it up from one end to the other, widely exposing the lower uterine segment and the shiny glistening pubocervical fascia. As you see here, we apply the roomy uterine manipulator. So over the cup, it is very easy to push the bladder down and open up. Now this is the opening up of the iliopectineal ligament. Now we go on the other side and below the round ligament and the V formed by the external iliac vessels and the round ligament. Now this shiny glistening structure which I am exposing by the harmonic ace is the iliopectineal ligament. So now we take a mesh which is 3 centimeters in width and 15 centimeters in length, and now we are fixing the mesh over to the cervical isthmus by the use of proline or epibond. Here the suture material used is proline, but the proline has a lot of memory, so nowadays we prefer using epibond. So now the mesh is snugly fit over here, and since it is synthetic material, we need to take at least 5 to 7 screws and knots. And now we are passing the bite through the mesh and now through the iliopectineal ligament. We take minimum of 2 bites deeply into the iliopectineal ligament. So the iliopectineal ligament is the posterior prolongation of the Cooper's ligament, because the Cooper's ligament all of us are very well aware of. So towards the cranial end of the patient, the prolongation of the Cooper's ligament is the iliopectineal ligament. So you will be very glad to know that it was an Indian, Dr. V.M. Joshi, and he has several publications starting from 93 onwards in several international journals. So he was the one who gave this technique to the world. At that time, initially he did it with open technique, but later on they converted it to a laparoscopic procedure. So this was the surgery we had demonstrated in IAGE, and for many of my colleagues in the Western world, and including the moderators, they found it a new and a very useful technique. So after fixing the mesh bilaterally, we close the peritoneum. The benefits here are that it gives a bilateral support and it does not unduly tend the vagina, as this fixation is done at the level of S2, and it is more physiological. It is within the reach of an average endoscopist, as we do not need to go right up to the sacral promontory and the dangers of injuring the middle sacral vessels over there. But the best what I find is that it is a bilateral support, does not hamper with the blood supply or with any major vessels. So this is the completed picture, and that's the vaginal end. The prolapse is completely repaired. So how we can further apply pectopexy is a case of vault prolapse. So if you see here, this is the vault and which has been corrected, and we have taken series of sutures in the pubocervical fascia, in the vaginal apex, and into the internal oblique muscle, and then the mesh has been fixed over here. So if you see, we make a broader mesh at the apex of the prolapse, and then these two arms, they go over to be connected to the iliopectineal ligament, and this is the completed picture. So this is another application, another surgery which can be offered for vault prolapse. But it's not only simple. We need to remember when we do pectopexy that there could be injury to the obturator vessels, and more so as we are these days battling with corona. In pectopexy, like supposing this is the Cooper's ligament and these are the corona mortis, the accessory obturator vessels. So these can get injured because the mesh is fixed over here. So what I do routinely is that go and coagulate them in the beginning of the surgery. So another video which we will show here is the use of muslin tape to correct for hysterectomy. So muslin tape is the one which we use for our McDonald sutures or the Shirodkar sutures. So first we open up the sector and expose the sacral promontory and go right up to the insertion of the right uterosacral ligament, and here this is the anterior compartment. The bladder has been pushed down, and this is known as a site-specific repair, wherein I am taking bites and sutures in the pubocervical fascia and taking care of the anterior compartment and taking care of the cystocele. So the laparoscopic management of cystocele is by doing, and now again posteriorly I am plicating the uterosacral ligaments. So posteriorly we are doing the plication of the uterosacral ligament. So this is known as a global repair. Anteriorly we are plicating the pubocervical fascia, and posteriorly we are plicating the uterosacral ligaments, and thereby giving a total repair anteriorly as well as posteriorly. So once this has been done, it is an excellent repair for the posterior compartment. And now we will proceed to apply the mesh. Now the mesh has been delivered by the lower grasper, and from anterior to posterior, taking care of the uterine arteries, the muslin tape is brought out, and the same is done on the other side. The muslin tape delivered out. So these are the cases which can be utilized for grade 3 prolapse, and we take a bite into the anterior longitudinal ligament and take another bite with another needle. So these two, we make a snugly knot over the sacral promontory, and I will just show you the pelvic end, how the prolapse is repaired, and we need to reperitonize the defect from one end to the other. So that is a completed picture. And we always do a hysteroscopy at end. So the same procedure can be done, and we have to do the prolapse repair along with total laparoscopic hysterectomy. So we see here, I am doing the TLH with the help of harmonic phase and also with the measure or the NCL. So then we anterior repair by doing the plication of pubocervical fascia, then the mesh is fixed over here, and then the mesh is fixed over to the iliopectineal ligament, And this is the completed picture, that this is the vaginal wall duly supported by the bilateral application of the mesh to the iliopectineal ligament, and we always do the posterior repair in the form of plication of the uterosacral ligament. So I'll just put in a word about the laparoscopic management of SUI. So birth corpus suspension, many of you might have done by the open route, but in the modern era, it's good to do it along with TLH, or so this patient had previous 2 C-sections. So we are just introducing our way of making entry in a case of previous multiple surgeries. So this is we call as a Jen point. It is para-umbilical in position. We first locate the anterior superior iliac spine. We draw a vertical line, and then where these 2 lines meet, the J is for the Jen point. So we just make a small stab over here, and then we introduce the Verey's needle in an absolutely vertical direction, and we hear the 2 pops and the feel of the give of resistance as the needle enters the peritoneal cavity. The CO2 pneumoperitoneum is carried out. The 5 mm telescope is introduced, and then the 10 mm trocar entry and the telescope entry is under the vision of the 5 mm telescope. So this is an excellent way of avoiding adhesions at umbilicus, or even in a routine manner to not to make a blind entry at umbilicus and to avoid the major retroperitoneal vessel injury which could happen at the umbilicus. So inside, we first inflate the stomach with the bladder with about 200 cc's of normal saline, and now I am making entry into the space of radius. You can see this by the cotton candy space, and this is a lovely exposure which we get. Now this is the entire Cooper's ligament. Now one of the assistants puts the finger in the vagina and raises up the paravaginal tissue, and we take, this is the ethibond suture, and we take 2 or 3 bites, and now this is over the Cooper's ligament, over the pubis, which is next to the pubic symphysis. Then we make these throws and knots, and all of us know that whenever the patient has a sneeze or a cough, the intra-abdominal pressure rises, but this suture will make angulation of the vesico-urethral junction, and the patient becomes continent. So in this way, we take sutures, 2 sutures on either side. The first suture is at the close to the 1 centimeter from the pubic symphysis, and the other is placed another 1 or 1.5 centimeters towards the cranial end. So they are never made too tight, they are just a sling. If we make it too tight, the patient can has problems and difficulty in passing urine. So in our series, we have never had any problem with my video. So the same type of sutures are applied on the other side, and it is completed. So I will just go over to the next video, that is the paravaginal defect repair. Maybe it could be a new surgery, but I remember I had presented this in the Foxy in Agra in 2004 when my first book was released. So in paravaginal defect repair, the bladder gets detached from the arcus tendinous fascia white line, and we have to just, as shown over here, have to suture it back. So now in this video, we already have entered the space of radius, and in the same manner, we take these 2 bites in the paravaginal tissue, and now I will show you how beautifully in laparoscopy you can see the arcus tendinous fascia white line, and additionally we can take a bite in the muscle white line. The muscle white line is the fascia covering the obturator internus muscle. So, and it is also dependent upon the defect. If we have a large cystocele and a large paravaginal defect, we can even take a bite from the lower limit of the Cooper's ligament. So it takes care of the SUI as well as of the cystocele all in one go. So we have to take a series of sutures starting from the level of the ischial spine and going towards the Cooper's, towards the pubic symphysis, and the same sutures are done on both the sides. And at the end of these type of repairs, a cystoscopy is a must to see for that no suture has come inside the bladder and for the bilateral ureteric spurt. So now I am taking good deep bites one after the other, and this gives a very snug correction of cystocele, because nowadays what I am seeing is that many elderly women, they have the cervix well at the level of the ischial spine, means it is well supported, but they have large cystoceles. So along with TLH, this comes out to be a very handy procedure, and we have done a lot of such cases, and our patients have had a long follow-up with good results over the time. So in the same manner, all the sutures are applied, and this is the completed picture, and the peritoneal coverage is done after the surgery is finished. So we have good results after the post-operative recovery, no recurrences. And in conclusion, for pectopexy, I would like to say that it is a useful tool in the armamentarium of gynecological endoscopists for hysterospexy, for vaginal wall repair, and also as an adjunct with TLH, and also for the repair for laparoscopic supracervical hysterectomy. So it could be a good procedure, or at least a new tool in the basket of several procedures. So as introduced by the chairperson, we had relayed the surgery live to IAGE, and Andrew Sokol, who was a senior, my moderator, in the next year's IAGE meeting, he said, when the head of the radiology, she came for the prolapse surgery, I told my residents, let us take out Dr. Jain's video and do this procedure for her. So this is I have good big thanks for my team, which has always supported me, and thank you all. Thank you, UP, IAG, Niranjan, and all the stalwarts, the guests of honor, for giving me this opportunity today. Thank you so much.
Very nice presentation, Dr. Nutan. And here I have this question that how do you make sure that this vaginal axis is correct in pectopexy, or means, if we don't look on this particular part, then it can give rise to SUI, means stress urinary incontinence, or some problems in defecation.
Definitely. So first of all, what I said, why I said near is that whenever I do a pectopexy, I never do it alone, only the mesh part. If you have seen all my videos, we first placate the pubocervical fascia. We take a lot of sutures and we obliterate the hiatus through which the bladder can prolapse. And over that buttress platform, then we apply the mesh. So, and as I said, it rises the vagina only up to the level of S2. So these patients are really at an advantage. They do not have any anterior compartment complaints or defects in the later on. And as you see, we always do a global repair, meaning thereby that I augment the posterior compartment by taking bites in the uterosacral ligaments separately in the posterior compartment. So once you have augmented the anterior compartment, also the posterior compartment, it gives a level support and a bilateral support which is at the level of S2. So these patients are having an advantage of not unduly tenting the vagina, and they get it up to the level of sacral promontory. So pectopexy that way, and then none of the nerves are disturbed. There is no dissection in the posterior compartment. So these patients do not have any voiding or defecation disorders, and sexual satisfaction is better as the vaginal length and the angulation is well maintained.
And relapse rate? Relapse any?
What I would like to say here is that these patients, because many of these patients who have delivered in a rural setting, or they have chronic cervicitis, so their cervixes are usually hypertrophied. So at times the cervix can come up to just -10 or just inside the introitus. So the patient at times feels that she is looking at her cervix. So for a patient if you see that the cervix is hypertrophic, we can use monopolar and we can do a little amputation of the cervix and to bring it at a good decent level so that the patient does not see it in the post-operative phase.
Okay, Dr. Nutan. Dr. Chavan, do we have more time for question answer? So should we ask others for question or we should proceed for the next?
Madam, one more question and then we can go ahead and call upon Dr. Kiran Pandey. She is our guest of honor. She has just come. One more question you can take.
Any complication related with mesh did you find, Dr. Nutan?
Yes. So mesh has known complications, but in our cases of rectopexy, if you see that we are attaching it over to a bone which is at the level of S2 and the bladder is nowhere coming in contact with it. So we did not have any complication of the mesh because we've been doing this procedures say about 3 years from IAGE and 1.5 years before that. So the only problem the patient complain is a dragging pain, and this dragging pain is also more in the initial part, and then within about 6 weeks or 6 to 8 weeks that subsides. So our problem, the only thing with patient at times complaining and those hypertrophied cervices that they could see the cervix while they are squatting or the ones who are using the Indian seat. So now we have learned that to do some amputation and give a decent look of the cervix, and then the patients and the conception rate and the further, like if you see here, we have applied the mesh just below the cervico-uterine junction. Okay, so if you have to do a C-section for such cases, you can have the mesh still intact and do a cesarean section above it. So this is also a very good point. And during pregnancy also, because it is at the same level as S2 and not so higher, so the patient does not have too many problems during her pregnancy.
Thank you, Dr. Nutan. Really elaborate presentation in such a short time. Thank you. Once
I did hurry up because keeping other speakers in mind, you have a good lineup. Thank you. I really enjoyed being with all of you.
Dr. Nutan.
Hi, Surita.
Hi. Thank you so much. I have just a small question about the Jan point. Exactly, why did you start with doing this Jan point? Was it only for the adhesions, or was it for some? Are you using it for other surgeries also?
Yes, Dr. Surita, that's a lovely question. And now we are good. We have 7,500 cases done purely with Jan point. So we had started doing it in cases of previous surgery to avoid adhesions, in cases of COX to avoid those multiple adhesions. But now we are following the protocol of a non-umbilical entry. Every time, every case, obese, thin, large mass, cystic mass, huge solid tumors, in all of them it gives a benefit because if it is a midline vertical scar, it is so much lateral compared to the Palmer's point. And we have a publication wherein we have introduced that for the upper abdominal scars. In the upper abdominal scars, the Palmer's point is a contraindication. So there only Jan point comes as a handy choice. So now what we do is that all our fellows, trainees, we have a very active training program, and I give them all sorts of entries, and they start with the Jan point with a very needle because the insertion is very simple. We tell you not to raise the abdomen, go absolutely in a vertical line, feel for the two pops, and once your needle is inside, only then start the pneumoperitoneum, and then introduce a 5 mm telescope. So once you look around everywhere, you see that there are no adhesions or whatever the point comes out to be best for the 10 mm trocar. From there we make the entry. So Jan point becomes very versatile, and once you keep on doing it every day, so once you have a complicated case, a challenging situation, so you don't spend your night wondering from where I will enter, you know Jan point will be safe for you. So that is it. A non-umbilical approach and blind for the first blind port.
Thank you.
Thank you so much, Dr. Nutan Jain, and wonderfully conducted by Dr. Ori. And we have got many questions lined up, but due to constraints of time, we will have to move ahead. And now I call upon Dr. Kiran Pandey from Kanpur. She was having some connectivity issues and she is the guest of honor with us today. She's a professor and head. I have already introduced her CV to all the users who have logged in and the faculty and the presenters. So I request Dr. Kiran Pandey, madam, to please inspire us for all the members who are watching us. And
Thank you.
Go ahead. Thank you.
Thank you, Dr. Niranjan. Yes, I had some connectivity issue, but now I've I'm there. So thank you very much for inviting me as guest of honor, and thank you very much all the UP IAGE president and secretary and the chief guest, Dr. Chandra. I was able to hear, so I heard Dr. Chandravati and the other guest of Dr. Anupam. Wonderful presentation by Nutan Jain. He always presents, shows innovative videos, and Pectopexy was a very good thing. And in fact, you all know endoscopy is day by day coming up in such a way that it is almost most of the surgeries can be done. I can't say it is replacing the open surgery, or it can, because everything has its own role. But definitely for youngsters, this is a wonderful webinar initiative which you have taken, Dr. Niranjan. And such wonderful speakers are there, and interesting videos are also in line. So I'm sure everyone will be benefited with these interesting cases and the ideas. I'm very thankful again, and without taking much of your time, I like that our audience sees most of the interesting cases. Thank you very much, really. It's a pleasure to be part of it.
Thank you, madam. Now I hand over the mic to the next chairperson, and we have already introduced them. So will you please take the charge and introduce the next speaker, Dr. Amit Tandon. Nisha Singh ji, please.
Yeah. Thank you so much, Dr. Niranjan, and good evening, everyone. So I'm here to introduce our next speaker, Dr. Amit Tandon, who is an assistant professor in the Department of Obs and Gynae, SNMC, Agra, and he has had special training with laparoscopic surgery from Cochin and Mumbai, and special conference with laparoscopic surgery national international operation faculty in gynae endoscopic surgery in various conferences. And we all know him. He has undertaken Vardheim's operation training, fellowship in gynae oncosurgery from Tata Memorial also, and experience of performing lap doing open Vardheim since last 6 years. And so I invite Dr. Amit Tandon now to deliver his talk here and show us some more interesting videos. Dr. Amit Tandon, please. Dr. Amit Tandon, you can share your slide. Yeah.
Yes. So at the outset, I would like to thank. Can I be heard?
Yes, sure.
Yeah. Okay.
I can hear you. Yeah.
So the first of all, I would like to thank.
Amit, before तुम start करो, मैं तुम्हें पहचान नहीं पाऊँ.
जी, मासी जी. Hello.
Yeah.
Okay. Yes, so I would like to thank our Dr. Raj Baveja ma'am, Dr. Chandravati ma'am for gracing this occasion, Dr. Jaideep Malhotra ma'am for coming, and Dr. Anupam Gupta, Dr. Ragini Singh, and our chairpersons, Dr. Rakhi Singh ma'am, and Nisha Singh ma'am, and Dr. Neelam Mori ma'am, and Dr. Surita Karim ma'am. And also thanks to Dr. Niranjan Chauhan for organizing such a nice webinar and giving me this opportunity.
Sir, it is all because of you, sir. It is all efforts which you and sir has taken, and I never realized that the program would be such a beautiful way it will come out. I mean, amazing, the videos which our colleagues have given today, and I'm really astonished with such a beautiful chief guest and guest of honors and the lineup of the speakers and the panelist video. It's amazing. Thank you, sir, so much.
Thank
All
you.
of you.
Okay, thank you. So my presentation today is surgical strategies and techniques for a difficult hysterectomy. So we all know that the origin of laparoscopic hysterectomy started with this landmark paper and by Dr. Harry Reach in 1989. And laparoscopic hysterectomies have been clearly associated with relatively lesser blood loss, shorter hospital stay, speedier return to normal activities with the concept of daycare surgery, better cosmosis and patient acceptance, and fewer abdominal wall infections when compared with abdominal hysterectomy. The vaginal approach is less expensive but may be challenging in patients with a history of an adnexal mass, endometriosis, pelvic pain and prior abdominal surgeries, and in patients with the narrow pubic arch or a poor vaginal descent. So, the main positioning of the patient is placed in a Trendelenburg position for a better access to the pelvic organs. The patient's arms are tucked in, the legs are flexed at hip and knee joint, and placed in a stirrups using caution to prevent compression on the lateral half of the, thus preventing the peroneal nerve injury. So this is the standard position of a laparoscopic hysterectomy or any kind of laparoscopic surgery. These are the instruments of the part of the armamentarium. So this is a simple laparoscopic hysterectomy which is being done, which in a normal case, and after taking the adnexa and the round ligament, the broad ligament, both the leaves of the broad ligament are open anteriorly and posteriorly, and then after skeletonizing the uterine arteries, they are coagulated, and then the Mackenrod's ligament are taken, and the vaginal vault is closed. So the biggest thing in a patient of 12-week size uterus, the sacral hollow and the distended abdominal wall provides a big space all around the uterus to maneuver and to see the anatomy of the ureter and the uterine artery. So the problem arises when there is a huge fibroid or the size of the uterus is very big, or there is a large ovarian cyst, endometriosis, severe infections. So the main purpose of this study is to get acquainted with the anatomy so that in any kind of hurdle we are able to overcome the obstacles and without injuring the structures which are in and around the uterus, and so that we can complete the surgery without damaging the organs around it. So this is, you can see, taking the uterine arteries, and I'll just fast forward it because so what are the conditions where we need to, which can distort the pelvic anatomy? Fibroid of the uterus, large fibroids up to 12 week size, maneuvering from below is sufficient. Beyond 12 weeks we need something from above to maneuver the uterus. Endometriosis with obliteration of cul-de-sac, severe uterine adhesions to the bladder and anterior abdomen like after cesarean section or myomectomy, dense ovarian adhesions in the ovarian fossa and parametrium with or without retroperitoneal fibrosis, obesity which increases the retroperitoneal obesity. So now what are the general surgical strategies we should be undertaking while working with the large uteruses or with distorted pelvic anatomy? Work from known to unknown. So first, whatever pedicles which are clear, which are anatomical, we should try to handle them first, and then we should approach the other pedicles. Define your anatomy and re-establish the landmark and perspective. So detail about the retroperitoneal anatomy is must when we are going to do a complicated hysterectomies or a difficult hysterectomies with frozen pelvis or endometriosis. The ureter and the uterine artery origin, course must be known in detail. Find the gateways. If the adhesions are bad, open the retroperitoneum which will release the adhesions, and then you can proceed with the surgery. And next principle is avoid direct confrontation with the pathology while going through the above. What are helpful tools in difficult hysterectomy? Angle scope, a 30-degree or a 45-degree scope, or flexible scope which are produced by Olympus are good options. Uretral stents can be used. Use of myoma screw is a must, and a uterine manipulator with a well-fit obturator is also helpful in delineating the cervix. Powerful morcellator is also helpful, where once after you are securing the blood supply, you can cut the uterus and then take it out. So this is the typical port placement. Port can be placed at the umbilicus for a normal sized uterus, or with 2 mm, 5 mm secondary ports and one 5 mm port at the mid umbilical region. For larger sizes, we can move up as shown in this diagram. The basic principle is your primary trocar should be, your telescope should be at least 7 to 8 centimeters from the fundus of the uterus, and your secondary trocar should be 4 to 5 centimeters away from your pedicles. In very large uteruses of 36-week size, 34, 36 size, one may have to go to the either sides to tackle the pedicles of that side if it is not possible to tackle the pedicle from the contralateral side of the opposite side. And the primary trocar can be taken up to the Ziphi sternum. So when we use a 0-degree telescope, and this is the picture of a large fibroid, we tend to miss the bladder reflection on the cervix, and we are not able to see the cervix, like in this diagram. When we use a 30-degree telescope, we are able to identify the cervix, the reflection of the bladder from the cervix, and we can see the anatomy all around the uterus. Another important instrument which for
Getting the audio of Dr. Tandon.
Yeah. The audio is not there. Is it just for me or everybody?
Yeah, it's not there.
It's not there for everybody.
Yeah. So,
Dr. Amit?
Your slides, Dr. Amit, but not your voice. We cannot hear you. You are unmuted, but somehow the voice is not coming.
Dr. Amit? Sana, are you there?
Yes, ma'am.
Yeah, we can't hear anything. I think no audience can hear anything. So can you please check and...
Sure. I'll just call Dr. Amit and check.
Yeah, please.
No, but we are not able to hear.
But I think he was very nicely describing the points that should be taken care of when you are dealing with, large size fibroids or large masses. The approaches that could be there, the lateral, the ports that he was mentioning for seeing the pedicles when you are not able to do that from a single umbilical or supraumbilical port.
So I think he's got the message because now he's not moving his slides.
Such large uterus, I think in 1 or 2 cases I have used the Jan point which Dr. Nutan was talking about earlier. And there we can, these kind of difficulties are overcome if we use the 5 mm telescope through that Jan point. And it's quite a good tool to have. So I think that is a really novel point which we are proud that Dr. Nutan Jain has come out with that. And in the future, I think a lot of people will benefit out of that, using that Jain point more and more often, especially with large uterus and with adhesions, of course.
Thanks, Dr. Surita.
We can hear you.
You can hear me now?
We can hear, but there is a little disturbance.
Okay.
The background noise is there, you know.
Background noise is there. Background noise also.
Some people have joined with two devices. That's why the background noise.
Okay, let us hear. Just go ahead.
Sir, please go ahead. We can hear. We can hear your voice.
Please go ahead.
I'm back.
Yes, sir. Thank you. Thank you. Yes, sir. We are just waiting for Amit sir to finish his lecture. Thank you.
I think Amit is speaking, but his audio is not audible to us.
Yeah, if he can just remove his headphones and directly talk to the laptop, then also we can hear it.
Okay.
हटा दो अगर पीछे से.
Yeah, Dr. Amit.
Yes, please. You can directly talk to the laptop rather than putting the headphones and plugging it.
Hello?
Yeah, we can hear you.
Yeah, you can hear me now?
Yeah. Please just talk loud and you can continue to talk. Please go ahead.
We can hear you.
You don't need headphones, please. Sir, requesting you to talk directly onto the laptop without using the headphones. Please do not connect those headphones to the laptop.
Remove the headphone connector from the laptop jack.
Yeah, remove the headphone jack from the laptop side and just directly talk.
नहीं आ रहा.
नहीं. So should we go ahead with the next lecture then? In the meantime, we will fix his. We will start the lecture.
Yeah, I think Dr. Malhotra is there, so we can do that.
Yeah, because it's been more than 5 minutes, sir.
Yeah. So we'll.
Yeah.
Yes, sir.
I think we will have to stop sir's transmission and go ahead with Dr. Narendra Malhotra sir lecture.
Then sir, stop sharing the screen.
So you please.
I request Dr. Amit Tandon to please rejoin again, choosing the computer audio option.
Thank you.
Please log out and log in again using the computer audio sharing option.
I request Dr. Surita Chatterjee Karim to please introduce Dr. Narendra Malhotra sir. Please unmute.
Thank you. Yeah. I think you have given me the easiest task in the whole today's evening program, because I think Dr. Malhotra needs no introduction to any of us present here, and of course he is keeping on adding laurels to his already distinguished profile, which we can see on our screens. And so I would, instead of wasting more time, and we all have a great privilege that today he is there with us and he is guiding us along with his great wisdom. So I invite you, sir, to kindly deliver your lecture. Dr. Professor Narendra Malhotra.
I would like to add that sir is the chairperson of the UP IAGE chapter, and he has taken this initiative of getting all of us, all the provinces from Uttar Pradesh to come together. And sir, when the whole program was formed with your guidance and the encouragement, the tips which you have given and the tricks which you have given, at the end of the day, I am astonished at the way the program has come out, sir. Thank you so much. And you have been always a guiding force in Foxy, in SR, in IAG, ISPAT, and a professor. Amazing, sir. And the amount of energy you have, enthusiasm is nobody can compete, sir. So please go ahead, sir, with your hysteroscopic corrections of cavity disorders. Thank you, sir.
So thank you very much. It's indeed a pleasure to be here on this webinar for UP. We were planning this for a long time with Nutan Jain, and when Niranjan said that can you do it here, though today was a very, very busy day, but yes, we can do it. That is, we never say no. So correction, I'll quickly take you through whatever the problems we have in facing a look into the uterine cavity. And we'll try to tell you some tips and tricks, the 6 tricks which I employ for my hysteroscopy. Firstly, remember that there is an anatomic factor for recurrent spontaneous abortions and problems. And the best tool for diagnosis is now transvaginal and 3D ultrasound and not HSG as it was. But we have not yet given up HSG, but I now rely more on my own 3D ultrasound, which I'll. So the tip number 1 is that you do a proper cavity evaluation and know the cavity problems and classify them. You can do with hysterosalpingography, sonohysterography, color Doppler, 3D, 3D with contrast, 3D with HD Shilute imaging, and of course MRI. So this was the older classification, the American Society of Reproductive, where the abnormal uterine shape was classified as 1. But now we have the Escher ESG classification, and look at the Escher ESG UCO classification. Look at them, the classification and my 3D. Absolutely, we can pick up all of them, any of them, with a well-done 3D ultrasound. Because we get the coronal view, which was not possible with 2D ultrasound. So when we classify the U anomalies, the U0 to U4, see how we get the coronal view, this view. Normal uterus, biconvate, arcuate. Now there is nothing as arcuate, all of them are now known as septate uterus. So I always say that you have 2 magic sticks in your hand, and you have to be a master of both the magic sticks, the ultrasound, the transvaginal probe with the 3D and color. Even if you don't have the 3D, at least color should be there. And then of course the hysteroscope in your right or the left hand, whichever you are more comfortable with. And then of course when you leave both of them, you need the laparoscope to be pretty averagely good at laparoscopy also. So today we are going to talk on uterus, as you can see the red. So we analyze the uterus by HSG, and if you're going to do an HSG, you please do it yourself and do it under fluoroscopy like this. So not a single film will sometimes, HSG is done in radiology centers where there are fracture patients, tuberculosis patients, and there is a lot of body odor in that HSG room. And a lot of dark, smelly technicians who are unshaven and they're abusing, they're talking, everything, and poor lady, jaldi se let ja, kapde utar, then some doctor comes running, jaldi leto, mere ko apne clinic mein jana hai, dye lagao jaldi. So it's all crazy. I mean, you don't treat women like that. So if you have to do your HSG, do it yourself, do it like this, as I do it. And then only you can get. Otherwise, we do is we put in a Foley's and we inject saline, as you can see here. And here you see how beautifully I picked up an Asherman and how beautifully I picked up a floating polyp with some saline. So this is the way and this is done in your clinic. When you're seeing in the OPD, the ultrasound is right next to you. Just put in a feeding tube, inject some saline and do a TBS. No 3D, no color required here. So polyps, fibroids, the hysteroscopic finding later on. You can see here, and as we saw it in this picture. So absolute correlation. You see this band and you see what the band I diagnosed. So I'm ready absolutely what I'm going to operate at. So once you have 3D, it is definitely an advantage. And see, the advantage is because you know the outer contour, the inner contour, the cavity, and then you can erase everything electronically and just get the cavity highlighted, and you can rotate the cavity to look at it from all other sides, which you cannot do by any other modality. And you can get pictures like this with Shilute imaging. And you can get pictures like this. So this is what 3D has done. And you can, when I put saline and use a high definition Shilute imaging, see the cavity and see the fibroid jutting into the cavity. So now I know that this will not come out by hysteroscopy. or we have to do it in 2 because it's more towards the surface. So I would be more comfortable taking it out laparoscopically, but do a hysteroscopy. See, look at the unicorn. Unicorn expected at 3D, unicorn picked up by 3D, and then my hysteroscopy showed exactly the same picture what I saw in 3D. So this is what is required as a very, very good idea. Unicorn with this side or that side, which the 3D will tell you, and your hysteroscopy is just for confirmation. If the cavity is very less, I would go ahead and do a little lateroplasty and inject some PRP, which I'll just show you. Duplication anomalies, yes. Now sonohistography 3D is almost 98% with 100% specific. So all duplication anomalies, septate uterus, symptomatic, asymptomatic, spontaneous, need to be corrected before, if this patient is picked up in infertility. If she's picked up as a bad obstetric history, yes, we need to correct it very nicely. So a normal cavity, a septate uterus, or a complete septa or a partial. Now this is the vaginoscopy, and see, I'm going right into the cervix, and I follow the longitudinal lines of the cervix, and I enter the cavity. No holding of cervix in 5 minutes, and you see the septa is coming right till the lower segment. So I go in one side, check up this cavity, and go on the other side, and with my scissors, current, whatever you want to use, we'll try to use the scissors for this thin one, but if we have thicker one later on and it's not coming, we use a bipolar cautery with normal saline, and we finish the surgery in only 10 or 12 minutes. Ultrasound will tell us it's septate. Ultrasound color Doppler will tell us whether the septum is vascular or not, and that is very important, because if there is scanty vascularization, there will be recurrent spontaneous failures, abnormal placentation. If there is no vascularization and there is a muscle in the septum, which it is now proven that septa are muscle and not fibrous, so that will cause incoordinate contractility, and that also causes spontaneous. So 3D pictures are like this, and 3D pictures are like this, and then we can classify by looking at the external contour whether it's biconvate or septate, which is very essential, because if it is biconvate, then the surgery is this. And this surgery, when I was a PG, was taught to me by open laparotomy Strassman's, but today we do it laparoscopically, and it does hold very well. So we don't call any uterus arcuate now with the new classification. We call them partial. This arcuate, which used to be, is partial or complete septa. And then we do a angle, and depending on the angle and the depth, we plan our surgery by hysteroscopy. So this is the most important thing, to plan your surgery on how you're going to do it. Now look at this one. Now this is the cervix. We're going into the cervix, and we have already found by the 3D that this was more a very deep septum. And once I enter the cervix, I've gone into one of the sides, and then I come back and I see that the septum is coming right up to the lower segment here. So now, because it was thin in the beginning and very thick and very big, so my scissors, I would have broken 2 scissors doing it with scissors. So I will use my bipolar plasma energy to cut this septum very easily. It was diagnosed by 3D here and measured. So I started with scissors, and once I reached a very thick part, then I switched over to the current, and the whole surgery finished in just less than 10 minutes. Your tip number 2 is that with every laparoscopy you do for infertility, combine hysteroscopy. Hysteroscopy has to be combined, because you do not know, even if you have done a very good 3D, you still might find some problem. Tip number 3 is use the right equipment. So our equipment for hysteroscopy should be very, very right and very good. And we should be very well versed with all the equipment which we use and how they assemble and how they, so do it yourself, assemble it yourself, take it off yourself, and then give it for sterilization. Now this is the controversial tip on dilatation, distension pressure. Now I was using a very low pressure in the beginning of my career, which was 10 years back or 12 years back, and was finding difficulty in operating and the operating time. But then, of course, we ran into the great Dr. Shawky. I am a big fan of his, because it's all about vision, hysteroscopy. And since then, we have been starting using. I'm not marketing this, but the good thing about this, which I found, is that you can regulate the pressure to high or low. So we put it on high pressure as soon as we enter, so it dilates the cervix because we're not holding or dilating the cervix. And as soon as we enter the cavity, we reduce the pressure, and we can control that. So this is what I found is very, very good in my practice. And see, that is how the cervix just opens with the pressure, and close, even the pinhole cervix just open up.
Hello.
And immediately you see the lesion, and once you see the lesion, you plan your surgery, and as soon as you plan your surgery, you can go ahead and complete your surgery. If you have the good distension, you complete your surgery without even once taking out the hysteroscope from inside, and completing the surgery in minutes. So it doesn't take, because we have to remove it complete. Now this was an IUCD which got misplaced, and we were just followed the threads up and just took it out. So distension media is very important. We don't now use glycine at all, because we don't do monopolar at all. We are doing only bipolar cut in all our this thing. We are fortunate that we can use it, and if you have money, invest in a bipolar cautery, which is very, very important. Tip number 5 of the 6 is individualized treatment according to pathology. So if you have Asherman, be prepared for cutting the Asherman, and by current or scissors. Classify it nicely first by ultrasound, and then remember that you have to see how many adhesions are there. Now this one, you see, we could locate that this had one big adhesion here and then 2, 3 here, and that is exactly what we found on hysteroscopy. So I was very, very prepared that we might have to use current here also, and we might have to use something for adhesion prevention, which is again a controversy. Of course, Asherman, mild, moderate, severe. I'm not going to the theory. Everyone can read the theory and everyone can go according to the theory. It's the correction of the cavity which is more important. See what ultrasound tells you: 1 adhesion, 2 adhesion, 3 adhesion. And when I put saline, the saline goes up to this adhesion and gets blocked there. So we know that is. So see, then we use 3D for Asherman also. So saline with 3D, and then correlate it with my hysteroscopy. Here was a single adhesion, here was multiple adhesions, cutting with scissors, cutting with current, cutting with bipolar current, cutting whatever. So that is how easy it becomes if you have the correct diagnosis with you. So then it doesn't matter whether you're going to use a monopolar or a bipolar, depending on what you have and how thick. Now this cavity was very bad, so we used the scissors, and then we also injected PRP in the cavity, which I'll just show you. So hysteroscopic adhesolysis, and I just wanted to show you this injection. Oh, something happened to the. So. Sorry about this. So PRP injection, we take the ovum pickup needle. See, the ovum pickup needle is serrated and it's got a good bevel, and we inject it subendometrially. We don't put it in the cavity. It will come out, and see the bulge. So PRP 1, PRP placed 1, PRP placed at the lateral wall after adhesolysis or in thin endometriums. PRP placed at the third wall and PRP placed at the 4 walls, and then a little bit at the fundus. And then immediately deflate the uterus so it doesn't come out. So placing it subendometrial, the results are just fantastic. That's what my paper is almost ready on about 100 plus cases. See, I'm placing at the fundus also. So complete cavity with the PRP, and here we're using it for the thin endometrium. So after adhesolysis, after big septum, after Asherman syndrome, you can use the PRP. Post-operative, I'm not going into the details. You can use, if you believe, put a balloon, put a IUCD, do estrogen. Septate uterus, I've already shown you, and it's very easy to cut septate uterus by scissors or by current, or by whichever way you're comfortable and what you have with you. in glycine. Now this was a big septum, so we put in a laparoscope also because there was a fibroid also. Now we did not remove the fibroid first. We will cut the septum first, and then, because if I remove the fibroid and had it gone into the cavity, then the septum would have been left and she had to undergo another surgery after some time. So a big septum and a very, very wide septum, again being cut by the bipolar current here. So we go from one side, always keep the ostia in place, go from this side, go from that side, always keep the ostia, and that is my guide to how far you see I'm using plasma, so you see there is no burning, no charring, and it is quite neat, and the whole cavity is huge. There was no fibroid jutting inside, so no hysteroscopic fibroid removal, and the fibroid was later on tackled laparoscopically in the same setting. Small fibroids by the loop or by the scissors, and now people just take it out with the scissors and leave the fibroid and it comes out. So which fibroids we are going to do? That is a clear-cut guideline 0, 1, 2 by topography, and it depends on the E score we make a E score, and then that will tell you whether they can be done hysteroscopically, whether they can be done by after GnRH, or whether hysteroscopy myomectomy is not indicated if the score is 7 to 9. So just that is what is very, very important. Hysteroscopic myomectomy can be very, very easily done by loops or even by scissors. So, and polyps, of course, again, we have done it by 3D, and we have done a niche mode 3D. So we have exactly known what the polyp is and taken it out very nicely. See the 3D picture and the actual polyp exactly matches. That is what I am going to stress. The diagnosis is more important than just putting in a hysteroscope. Lastly, narrow cavities, metroplasty also to increase the cavity size. And whenever we do a metroplasty, we again put in use PRP. So after opening up the cavity laterally, fundally, and in 3 places minimum, or maybe more. Now this is a very old video. This is a recent one. Then we go ahead and wherever we have cut for healing, we put in some PRP. See, that's how we do it, slowly, gradually. You can do it with scissors also. It was a very narrow cavity. And once later on, post-operative, 3 months later we did, it was triangular and the endometrium was growing. So metroplasty is another good operation to do for recurrent pain. Lastly, bony metaplasias. This again, we are seeing a lot of bony metaplasias because of mid-trimester abortions. And these could be causing foreign body infertility. So see the trabecular bone and the long bones floating in the cavity. Again, diagnosis by ultrasound and removal by hysteroscopy is what is simple. Just catch hold of each piece by piece. Now you'll say, I can remove it by curettage. Yes, you can remove it by curettage, but it will break. And if it breaks and splints, those small pieces will get embedded in the endometrium and they will cause calcification of the endometrium or inflammatory reaction of the endometrium. So please do see there is a small piece, this broke. So all these small pieces have to be taken out carefully and easily, patiently. That's how we do it. So lastly is the tip number 6 is that my magic sticks can go wrong. I can go wrong in my diagnosis by 3D because if I'm not technically sound in doing 3D. So there could be an equipment failure, there could be a procedure failure, and there could be genuine complications like perforations. So you should be well aware, and of course fluid overload. Pressures have to be correct. Do not use glycine. If possibly you can switch over to bipolar, and of course reduce your operative time. Be as quick as possible. 20 minutes is uterine time, which we time ourselves. If we cannot take it out in 20 minutes, then Lasix. We wait for a time. Let the give Lasix and let the urine flow out again, and maybe do it at that sitting, or maybe do it later at a later sitting. So, ladies and gentlemen, this is the greatest modality which we have to look into the cavity. Please give up doing blind DNCs for anything. No DNCs. Even if you're going to take a pathology biopsy, do it under hysteroscopic guidance. and do it without holding the cervix, do it with water pressure, and to negotiate the cervix. Any pinhole cervix can be negotiated. And of course, use PRP where you feel that it is going to help in endometrial rejuvenation. And use this needle and just see the bulge, and the PRP goes into the side. Thank you very much for giving me this opportunity to express my views in this interesting and very, very good webinar initiative taken by Niranjan, which we were planning for a very, very long time. And Nutan had told me long time back that we should be doing this, and we have finally done it, Nutan. Thank you very much.
Thank you, sir. Thank you.
Thank you.
I request Dr. Surita, Madam, to please, if you have any questions to sir, you can go ahead.
Thank you, Dr. Naren. That was excellent, and of course, as usual, you were brilliant. And but my one question is, how much PRP are you using for this injecting into the cavity?
So if you take 15 ml of patient's blood, you get about 4.5 ml of PRP made out of that. So we use all the 4 ml.
1 ml in one each ball.
If I'm going to do it in 4 places, 1 ml in 4 places, or half of ml in 8 places.
I've recently started using it for thin endometrium as a uterine in the uterine installation, but not yet after adhesions.
Try this, your results will be dramatically improved.
Thank you. That was a good tip.
Putting it inside the uterus, it comes out, and it doesn't go.
Yeah, it comes out. Yeah. Thank you. That was good tip. Yeah.
Great, sir. It was a wonderful presentation, and I want to tell you more than 500 users have logged in today, and we are in Uttar Pradesh, IAGE chapter. It is amazing, sir, the way you have explained today, and we want you to be there to guide us and inspire us. You are very enthusiastic and energetic. Now I would like to call upon our next guest of honor, who is also similarly in Haryana. I can say she's the Iron Lady of Northern India, Dr. Ragini Agarwal. I have already introduced your CV, madam. Thank you for coming today to the UP chapter of IAGE. You were busy in a panel discussion, and in spite of your absolutely haywire schedule, I know, I have seen it. You have been there. Thank you so much for being there. I request you to please say 2 lines.
Thank you, Niranjan. There's 2 things I cannot say ever no. One, to you, and second, to coming to my mother's land. So whenever any invitation from UP, it really gladdens my heart, and I'm so happy to come here and see all the friends, Dr. Narendra, Dr. Nutan, whom I admire so much. I think you use this word Iron Lady for Dr. Nutan only. She has made her place. When there's no female in the whole gynae endoscopy in India, and she has made her place in internationally, we all admire her like anything. And all the friends like Dr. Kiran Pandey, Amit, Aarti, thank you so much. I will not stand here in the academics. I wish you all very well, Niranjan and UPIAG. And over to you for academics. I'll be here for some time. Then I'll hop to another platform. Thank you so much.
Thank you. Thank you. Thank you, madam. And thank you, Narendra, sir. And now we go back to Dr. Amit Tandon. I hope he is ready.
Let me see. Let me try
Yes,
my.
please.
Yeah. Ye wala?
Yeah, now we get sound proper.
Yeah. You able to hear me?
Yes, yes, please.
We can all hear
Please go ahead.
Okay.
Yeah. Dr. Nisha Singh, please come.
Yeah, I'm there. And so we are so happy to have you back with us. Dr. Amit, please share your PPT.
Okay. इसको शेयर करो. Yes, ma'am.
And Dr. Malhotra, it was a wonderful presentation. We enjoyed that. And so now over to Dr. Amit Tandon
Yes.
for hysterectomy related talk. Yeah.
So, okay. So I'll start from the beginning.
You catch up from where
Okay.
you left. Yeah.
Yeah. Okay. I'll. So I was at
You were
the
talking
place.
about the big uterus and the extra ports that you need. Yeah.
Yeah. So after that, I think we had gone to the. Yeah, these were the extra ports which we were needing for the larger uteruses. So in cases of very big uteruses, more than 30 weeks, 32 weeks size, so we need to tackle the adnexa from both sides, sometimes separately, because it is difficult to reach the contralateral side from one side. So the use of 30-degree telescope, 30 to 45-degree telescope is very necessary in cases of large uteruses and complicated cases. This is just a diagram to show you that with 0-degree telescope we are not able to see the cervix, and then with the 30-degree telescope we are able to see the cervix and the reflection of the bladder. So now then next comes the use of a myoma screw for large and complicated cases. So myoma screw is an inherent part of large uteruses, and it can be used for various purposes, like for elevating the uterus, for anteversion and retroversion movements of the uterus, and for clearly identifying and seeing the vaginal fornices to enable a section of the anterior and posterior vaginal dissection. Also to elevate and define the cervicovaginal junction for a safer dissection of the vesicouterine folds and fascia. So this is the dissection, and the biggest use comes for this when we are cutting the cervicovaginal junction, especially before opening the vault. So this is the video of the myoma dissection. I'll just fast forward it so that the important points here you can see. This is the cervicovaginal junction, and here because no vaginal manipulator can pull such a big uterus so high, and with help of myoma screw we can easily pull the cervix up so that vagina and the cervix are easily delineated, and we can open the vault and then we can safely remove the uterus. So myoma screw, sometimes with a very large uteruses we might have to use a 10 mm myoma screw. And so next is, so there are two conditions where we must avoid the use of myoma screw. One is in endometrial cancers, where peritoneal spread of tumors is feared, and in patients with pyometra in cervical cancers, where insertion of the screw would lead to spillage of pus in the abdominal cavity. So the most important part of the difficult, complicated surgery, hysterectomy, is the ureter. So not knowing the location of the ureter halts the progress of a surgery for the careful and invites disaster for the careless. If I don't know where my ureter is going, I become a very, very slow surgeon, and every time I have to turn my telescope and see where the ureter is going. Ureter stents let you know the course of the ureter, so you can zip along when you are away from the ureter and refine your dissection as you get closer. So now even illuminating ureteric stents have come up, which can help you in the surgery, but they all are quite expensive gadgets, and sometimes if you know the retroperitoneal dissection well and you are well versed with the anatomy, you might not need it. So there are two approaches of ureteric dissection. One is the medial approach and one is the lateral approach. What we are showing you now is the medial approach. Medial approach means it is medial to the IP ligament, and lateral approach is lateral to the IP ligament. Here you can see the peritoneum is pulled 90 degrees from the site of origin, and then with the help of scissors we try to open the retroperitoneal space, and gradually we do slow dissection, and we are easily able to find the uterine artery and the ureter medial to it. So that was the uterine artery, and here you can see the ureter being dissected. So it is not necessary to go by the lateral dissection. Even with the medial dissection, with the help of a Maryland and open and a spread technique, you can detach the ureter from the medial peritoneal attachment, and then you can carry on your surgery safely in cases of endometriosis, where you need to remove the peritoneal deposits from the ovarian fossa, or in cases of large fibroids, where you need to dissect the ureter from preventing it coming along the sutures. So this is the lateral part. So now we'll come to the This is the medial dissection. So now we'll come to the lateral dissection. So this is the lateral retroperitoneal space. Here you can see with the yellow is the ureter. The left side is the internal iliac artery. Anteriorly you see is the uterine artery. Between the ureter and the uterine artery is the pararectal space, and between the uterine artery and the obliterated umbilical artery is the paravesical space. A detailed knowledge of this place is absolutely necessary. This is the triangle where we open the lateral retroperitoneal space, which is bounded by the IP ligament, the round ligament, and laterally by the external iliac artery. We use various instruments for opening this space. Here we are using the open and spread technique with the help of a Maryland dissector, and with the help of a monopolar we are opening this space and gradually dissecting the uterine artery and the ureter. So the ureter is attached medially to the medial peritoneum, and laterally you can see the internal iliac and the external iliac artery. This is the ureter which is adherent to the medial peritoneum. Once you get this ureteronium, you see the internal iliac artery, and you are able to clearly identify the pararectal space. Uterine artery is the only vessel which crosses from lateral to the medial, and it runs above the ureters. So here we are again with opening in the spread technique. We are dissecting the uterine artery, and we are defining the paravesical space anteriorly. And also another way of recognizing the uterine artery is coming back from the obliterated umbilical artery, and the first vessel which comes behind is the uterine artery. This is another way by which, so this anatomy landmarks and this anatomy, if it is well versed with us, we can easily perform any of the difficult cases, and later we will see how we apply this principle to various difficult circumstances of hysterectomy which we do. Even this part can be applied to open surgery as well, and it can be taught to the postgraduates both in obstetrics and gynecological emergencies. So next we come, so requisite of hysterectomy, the most important thing is ligation of the vascular pedicles. So, and without injuring the surrounding viscera. So we need to ligate 2 uterine artery pedicles and 2 corneal pedicles, either the IP or the uterovarian pedicle. So, and there are general strategies for hysterectomy. Always take the easier pedicles. Do not tackle the hard pedicle without securing the easier pedicles. Can always take uterovarian and go back for the IP ligament later, and can always take one IP and you sacrifice one ovary if the uterovarian taking the uterovarian pedicle is difficult. I'll just show you. This is a huge broad ligament fibroid arising from one of the adnexa. This is another picture of that fibroid, and here you can see that the uterovarian pedicle is little difficult. So if the other side ovary is normal, you can sacrifice the IP ligament of this side and sacrifice the ovary of this side and remove this ovary. And another important thing is here the IP ligament or the uterine is difficult. So you can 3 vascular pedicles you can easily take. The uterovarian of the left side, the uterine of the left side, and infundibulopelvic on the right side. And then you can tackle the uterine artery vessel on the right side in the last. Next comes how to avoid ureteral injury when taking the IP ligament. Ureter and IP ligament can be very close when ovary is adherent to the ovarian fossa and parametrium. Once ureter is identified, make a peritoneal window between the ureter and the IP ligament. Eliminate any potential thermal injury to the ureter. So this is a window which we made between the IP ligament and the ureter, and then we can take the IP ligament separately after dissecting the ureter. So uterine artery ligation. So there are 4 ways. Either you can take the ascending branch or anterior approach, you can take the posterior approach, ascending branch, or you can take the lateral approach at its origin from the internal iliac artery. So this is another, it is the same thing, but what is said here is summation style hysterectomy. Systematically disarm the opponent. The opponent is the ureter, and gradually by devascularizing the uterus, we are disarming the uterus, and then we can remove the uterus in a staged manner. Lysis of dense and fibrotic bowel and bladder adhesions. Whenever feasible, avoid lysing dense and fibrotic adhesions of bowel and bladder until all the uterine blood supply is secured. So this is about the anterior approach. Ligation of the ascending branch of the uterine artery without opening the posterior broad ligament. This is good for uteruses with large fibroid, uterus with poor access to the sac, cul-de-sac and posterior broad ligament. If the fibroid uterus does not and is not able to get maneuvered by the manipulator. It is not good for patients with endometriosis or dense bladder adhesions from the C-section. So this is a large uterus. Here you can see going up to the xiphisternum. Here it is easier to open the anterior fold of peritoneum, delineate the uterine artery, and then this is the posterior leaf of the broad ligament, and then you can easily coagulate the uterine artery. So this is called the anterior approach. This is bladder and this is the cervix, and this is on the right side. The posterior broad ligament is intact, the anterior leaf of the broad ligament is removed, and you are taking the uterine artery anteriorly. So, and what is the posterior approach? Ligation of the ascending branch of the uterine artery without developing a bladder flap. It is excellent in patients with extensive and dense uterine adhesions to the bladder and anterior abdominal wall, where sometimes you see the bladder is badly stuck to the anterior abdominal wall, and the uterus is also badly stuck to the anterior abdominal wall. Here the posterior approach is better. You dissect the leaf of the broad ligament, take the uterines, and then you can go and dissect the anterior part. It is technically usually not available during open surgery and is usually done in a laparoscopic approach. ये देखो फॉरवर्ड कैसे होगा? Just a minute. So lateral approach is commonly done in radical hysterectomy for cervical cancers. It is good for retroperitoneal fibrosis in the perimetrium seen in severe endometriosis, ovarian masses, large fibroids, and may be difficult to visualize without angle scope and broad ligament of uteruses. Here the lateral approach is used. Here you can see the umbilical artery, the obliterated umbilical artery, and the ureter below. So this is used in cases especially of endometriosis and severe PID. Here you can see the umbilical artery, the obliterated umbilical artery, and the ureter. And this is the lateral approach of taking the uterine artery, where large cervical fibroids are there, dense vascular bladder adhesions are there to disarm the opponent. So, and this is the two approach how we take the uterine artery. This is, you can say, the medial approach. Here this is the lateral approach. Here we see the obliterated umbilical artery and trace it backwards, and then we locate the uterine artery, and then we tie the uterine artery. Here you can see in this case of a large cervical fibroid, a dissection of the obliterated umbilical artery is done to trace it backwards so that the uterine artery can be traced to its origin, and then we can ligate it. So this is the normally the obliterated umbilical artery runs along the lateral margin of the bladder. So here we are dissecting it, and then we will cut some of the fat fibers of the bladder, and just a minute, I think. Here we, yeah. So I'll just show you the end result. Maybe the time. Here you can see we are we have taken the uterine artery. We have dissected the uterine artery of this side, and then we can tie it gradually or coagulate it according to our strategy. So this is one of the techniques where the posterior part is completely obliterated because of cervical fibroids or broad ligament fibroids or severe adhesions in the endometriosis cases. Here you can see the uterine artery originating medial to the obliterated umbilical artery, and then it can be easily coagulated here. So this approach usually is not needed, but one has to remember this approach to keep in mind in uh, cases where we can use it. So, here you can see some fibers are being dissected, and this is the uterine artery being taken. So and the next is the uterine artery we take from the origin lateral to the origin of the ureter, lateral to the course of the ureter, which is crosses the ureter at the level of the cervix. So here you open the lateral retroperitoneal space and identify the so now coming to other important things for large uteruses, and one of the most important thing is the bladder dissection. The lateral window technique has been greatly developed by our seniors, and it is very efficient method of opening the the prevesical space, especially in cases of severe adhesions of bladder to the uterus. So initially we were using scissors and a bipolar instrument. Now this bipolar shear has come up, which is very handy in cases of and speed up your surgery. It is a coagulator and a cutter. It serves both the purposes. So the important thing is we cut the leaf of the bladder, which is adherent to the uterus, and gradually the CO2 passes into the space, and this champagne effect which we see because of the CO2 going into the loose areolar tissue, and gradually we follow that course and keep on cutting. Sometimes there can be little bit of bleeding, one need not worry. And here you can see a lateral window develop. This was a recently done patient of previous 3 cesarean, and once you develop this lateral window, then you can go ahead and cut the attachment of the bladder from the cervix. Sometimes the bipolar or the bipolar shears can cause little coagulation, so your line of dissection can be little blunt, but you can sometimes also use scissors for doing the dissection. So I'll just fast forward it. Once you cut the bladder adhesion from one side, you can gradually move forward and do the dissection. Here you can see and sometimes we can take the scissors also for doing the dissection to delineate the clear attachment of the bladder on the cervix, and then if then once you are clear, you can cut after doing some hemostasis. And most of the time these minor blood vessels, they do not trouble you, so you can go ahead and keep dissecting with them. So
2 minutes please.
Yeah, okay, I'll just fast forward my so this is tackling of infundibulopelvic ligament and with large ovarian cysts. Sometimes large ovarian cysts are badly adherent, and sorry, just back, yeah. Sometimes large ovarian cysts are badly adherent, and I think video stopped playing. So just the and first we remove the mild adhesions, and then we go ahead and dissect open the infundibulopelvic ligament, dissect the course of the ureter, and then we can go ahead and remove uh, the ovarian cyst after uh, uh, removing the fluid from within the cyst. This was a large ovarian cyst which was adherent. So now when we can clearly go and do the dissection. So these I'll go to the next. This is a case of severe endometriosis where we need to know the retroperitoneal anatomy very well, and before going to remove the attachment of the pedicles from the uterus. So we are opening the left retroperitoneal space, vasopressin is injected, and then we gradually uh, then we gradually open the lateral retroperitoneal, dissect the course of the ureter, and just so are you able to get the videos clearly? This is the ureter course which we have dissected, and we are both
the video is interrupted, Dr. Amit.
Yeah,
it's a little interrupted. Yeah.
Okay. So here you can see this is the ureter being dissected, and gradually once we are able to delineate the course of the ureter, we can go ahead and we can cut the round ligament, and then we can you can also see the uterine artery going above the ureter. So once we step by step we delineate them, and then we go with our surgeries ahead. So next, I'm sorry, the video is little interrupted. This is in cases of cervical fibroid. Again, this principle of opening the retroperitoneum, dissecting the ureters and the uterine artery, and delineating the course of the ureter where along the fibroid is done by a lateral window technique, and then finally the hysterectomy is done along with this. I will just fast forward it so that other speakers get a time. Again, you can see the course of the uterine artery being delineated, and once it is, I'm just to complete the surgery. Once it is delineated, we dissect the anterior fold of the bladder, and once this is done, on the other side, we the ureter is of the other side. The ureter is dissected. And then finally the once this is done, the bladder, the cervical fibroid is opened, and from the vaginal end, and then we can remove the fibroid. So once we know where our ureters and the uterine arteries are, we can get a good sleep, and we know that we have not damaged any of these things. So the next, this is the one of the most difficult hysterectomies is severe PID patient, which she was having pus in the both the tubes, and for long she was being managed by medical treatment with strong antibiotics, but at a stage she was not responding, and hysterectomy had to be done. And here you can see how the adnexa are badly adherent to the bowel, to the uterus. So before we do the dissection of the lateral side, we must try to restore the anatomy of the uterus and the adnexa as much as possible, so that we can delineate the course of the vessels, we can delineate the pedicles, and then we can move ahead with the surgery. This was one of the quite difficult cases, and we are trying to dissect this laterally, and you can see some fluid collection, and because of the infection. And once we have restored the anatomy, and quite a bloody surgery sometimes, and then once we see we have opened the lateral parametrium, and we have delineated the course of the ureter and the uterine artery, and then rest of the surgery becomes relatively easy once we delineate the ureter, because we are not worried from where we are ligating the uterine artery. So just to summarize, know your anatomy like the cab driver knows the streets of Mumbai. We need to know more than one ways to get from point A to point B. So if in the jam you know the alternative route, try the alternative route when there is no traffic jam or there is no pressure, and know the freeways as well as the side street. So thank you so much for your kind hearing.
So thank you, Dr. Amit, and you have really very well taken all aspects of difficult hysterectomy, and I'm sure all the audience must have been benefited by that. And if there are any questions somebody can ask, I would like to make just two small points. With the use of the myoma screw, I remember once I was doing, and then the assistant just pulled it and the screw broke.
Yes.
Yeah. That tip of the. So, I mean, these are some complications that sometimes happen. And so I rather give them some kind of a blunt forceps or something to just push the thing away. And regarding the cyst, big cyst, as you said that you deflate it, and then I think very important to say that you have to have all reasons to say that it is a benign cyst. Yes. Otherwise, you should never do that. Yes. So those are the just two comments I wanted to make. If there are any questions, we can take one question.
Yeah.
Okay. So then I think we'll go ahead, and thank you so much, Dr. Niranjan, for having us here in this program and in the IAGE forum, because I have been moving more to the gynae oncology, but I've been doing lap surgery for 25 years almost now, learned from Dr. Alka Kriplani, whom I'll always remember for that. Yes. So thank you so much.
So next time, we will get one gynae oncology program for lap radical hysterectomy with Amit Tandon, with you and other members from all over India. I think that should be the next webinar, I can say.
Absolutely, I think we should have that.
Isn't it? So now all of you are so great, and thank you, all of you. Thank you, sir. We will go ahead with our video presentation. I can see Jyoti Mishra. She has been there smiling, and we will start with her video. We have got it downloaded. Thank you, Dr. Amit sir. I want you to be there because there will be some few questions which will be there. Anurita, nice of you to join from Meerut. You have been there from 5:45 taking care of Dr. Raj Baveja, madam. I am so lucky to have you as my friend sitting there. And there are many of you who have joined today. And we start with the wonderful video presentation which they have taken, 6 of them. They have taken a lot of pains to edit them, and they are really going to, you all are going to go on a roller coaster ride. I will be having Srikanth over here also. He's on the highway, 50 kilometers. He's on his highway. I am requesting him to be live also. Dr. Jyoti Mishra, thank you so much. Thank you all the chairpersons. I would like to introduce Dr. Jyoti Mishra. She's an associate director of JP Hospital, Noida, gynae endoscopic surgeon, Foxy endoscopy trainer, and she has many numerical publications to her credit. As we know, she is also the director of Blossom Women's Clinic, ex-chairperson of Noida Endoscopy Committee, NOGS, ex-North Zone Coordinator, Foxy Endometriosis Committee. I would like also Sana to please show all the efforts which Science Integra has taken. Here you can see Dr. Mimi Bindra, and she is MS, MHA, Fellowship in Advanced Laparoscopy, Advanced Infertility Training. She has got a lot of things to her credit. She writes books. She has got many awards to her credit, and we are going to hear from her. Thank you. Next. Dr. Neelam Mishra ji, she's from the president of Kanpur Obstetric and Gynec Society, director and chief consultant at Shivani Hospital. Well, she's a member of IAGE. She has got many awards. Thank you, madam, for accepting this invitation. We will be hearing from you soon. Next. Dr. Renu Singh Gehlot, again from Kanpur. She is a director of Gehlot Healthcare, Kanpur, laparoscopic surgeon and infertility specialist. She has taken diploma in gynae endoscopy, robotic surgical oncology fellowship, and she was also the member of the oncology committee when I was at the helm of affairs from 2012 to 2015. Thank you so much for joining. Dr. Aarti Luthra, she's from Dehradun. She is the founder chairperson of Uttarakhand ISAR 2018, vice president, Dehradun OBGYN Society, president-elect, and she has got many awards to her credit. She is popularly known in COVID times as doing the FB Live X-Files shows, and I have witnessed that. She is also invited as a speaker to various national conferences, including AAGL, IAGE, AICUG, ISAR. Thank you so much for coming and joining with us. Well, this is the young man, Dr. Shrikant Ori from Varanasi. I met him about 1.5 years back, and he has training from Israel, from Germany. He is also a member of the Gynecology Association of IAGE, ISAR, AAGL, IFS, ESHRE, has organized conference in 2019. That is a fertility enhancing endoscopy workshop, ISAR and ISPAT workshop. So welcome all of you today, and we start with a live video presentation from all of you. We have got more than 600 viewers logged in today, and all the best. Yes, Dr. Jyoti Mishra, please share your screen.
All right. Visible? Is it visible?
All others to mute their mic.
Okay. Am I audible and is my screen visible? Dr. Niranjan?
Yes, Jyoti, you are visible.
Thank you.
Dr. Jyoti Mishra, yes.
Thank you so much for inviting me here, Dr. NM sir and Dr. Chavan and everybody, Dr. Malhotras. And
yeah, please speak loud, madam. You please speak loud. Please.
Can you hear me now?
Yes, madam, we can hear you. Please go ahead.
It's just a 5-minute video as strictly told by Dr. Niranjan. So I'm going to talk about wall prolapse, which we see commonly in women who have undergone hysterectomy for vaginal route for prolapse. They come back more frequently to us because they have already the supports are poor. So I would start with my video, just 2 videos of each topic. This patient had a vaginal hysterectomy done for prolapse, and this was the wall prolapse which we found. So we start with dissecting the anterior longitudinal ligament. After inspecting the peritoneum, locate the ureter and lift up the peritoneum, give a nick and allow CO2 to fill up the space and create planes. We have to go along the right pelvic wall, keeping the ureter always in your mind. We don't need to dissect the ureter thoroughly because we know it is running on the lateral pelvic wall so as to reach the vault area. Now we dissect the vault, lift it up from below either by the blunt part of your vaginal manipulator or a sponge and holder. This dissection is required to push the bladder down because this is distorted anatomy. This is not a correct anatomy after surgery. So you need to push the bladder down and not take the sutures through and through. During dissection, we must keep good amount of endopelvic fascia with the vaginal area because the peritoneum, the vaginal mucosa is quite thin in these patients. They are usually elderly women. So don't strip off all the fascia from the vagina. Keep as much as possible on the area where you're going to apply stitches. This is the posterior part being dissected as down as possible. You must ideally reach the levator plate because that is the final point of insertion. This is a Y mesh being created. We take a polypropylene mesh and it should be a macroporous mesh to allow fibrosis to happen nicely, for allowing the fibroblast to grow. We use ethibond suture, which is a non-absorbable suture. Make sure that you don't take bites through and through the vaginal mucosa. After stitching the anterior and posterior wall, you pull the Y limb of the mesh and see that you don't do excessive pulling of the mesh because later on fibrosis will happen and that will lead to contracture of mesh. So patients will have problem. We are quite happy with tacker. We can also use a stitch on the anterior longitudinal ligament. And the last step is to cover the peritoneum, the mesh with a deperitonization, which we do with Vicryl and give a good wash. This is another case. This was a small wall. So I prefer that bigger wall prolapses are easier to suture compared to very small prolapse because the bladder overhangs. Now the problems which we were facing with mesh erosion were all these injury to mid-sacral vessels, hypogastric plexus, ureter. Because of Tacker's, patient would complain of osteitis. There were cases of sepsis, pain, and mesh erosion and others. Hence, then came the newer technique, which I have done a lot of cases of pec to pec C. Dr. Nutan has nicely covered, and I was a witness to her surgery in AGL. I was very much in the audience in Washington. So this is the iliopectineal ligament, which is the lateral part of Cooper's ligament. So this is correctly what I am doing. I'll show you when you start with a new technique. Sometimes we are wrong in our technique or the instrumentation. If we are doing using new for the first time, we have more complications till we get used to it. So this was the left side which you saw, and then we are taking, this is a dial shaped mesh we have cut, unlike the Y which we had cut there. The main broad area of the dial is being stitched to the vault, and then we'll go laterally. We can take a helical suture, take one bite through the mesh, and then this was the other side what I was talking about. I had gone to corona mortis. So this was the initial cases. The veins are lying right prominently over there. Gradually we realized we don't have to go too much cranially. We should be a little caudal in our dissection. So with every case we learn with our own mistakes, and it's a good idea to watch your own videos. This was another case. So with pectopexy, I have done enough of sacrocolpopexies, but wherever given a choice, I will prefer to do a pectopexy. In current cases, in the recent past, I have shifted to that. Although there's not a no to that. This is the mesh finally placed like a dial, and then we must reperitonize the mesh so that it is not exposed. There's nothing very, like there are a lot of controversies. There have been debates about which is better technique. But with pectopexy, you are in the natural planes, means the alignment of the vagina is in the natural area. The risk of injury to the vessels or nerves is less. Of course, you have the external iliac vein and the obturator nerve there. You always check the ureter that there's no kinking of ureter. If at all you find that they're getting stretched, you can give ureter releasing incisions. Cystoscopy we always do. Sometimes we have seen that we found a small stitch in the bladder. So then we cut the stitch through the cystoscope. So there's no defecation, constipation disorder, correct angle, no lateral cystocele. It is a simpler technique for younger generation to learn. SUI in both the techniques, the incidence of postoperative SUI was almost the same. So I would not say that which is good or bad, because I'm quite equally comfortable with both. But if I have to teach a novice, I would prefer teaching her pectopexy before, because the obesity with a lot of fat in the bowel, sorry, the same video has restarted. There is a problem in learning sacrohysteropexy, which is slightly more complicated surgery compared to pectopexy. Exactly 5 minutes, 30 seconds, Dr. Niranjan. Thank you.
Thank you, madam, for that wonderful presentation. And any questions by the chairpersons? Yes, Dr. Nisha.
I think
or the panelists can surely ask her.
That was a wonderful video, and because we have heard from Dr. Nutan already, regarding this, I think, not really a question to ask her.
Thank you.
Thank you so much. Thank you, everybody.
Yeah.
Thank you all.
Thank you. We go to the next speaker now, Dr. Vimi Bindra. Yeah, Dr. Vimi Bindra.
Hi, Dr. Niranjan, I'm here.
We are not able to see Dr. Vimi's screen. Sana, can you start the screen sharing?
I'm sharing the screen. Can you see my screen?
Yes, now we can see.
Good evening, everyone. Thank you so much, Dr. Niranjan and IAGE for the opportunity. And today I will be discussing this case where we removed 15 fibroids laparoscopically. So this was myomectomy for infertility. This lady was 32 years old, 10 years married. She had an infertility of 7 years, and she was referred by an IVF center for infertility, and they were planning to do IVF for her. Now, as she was planned for IVF, we did hysteroscopy to rule out submucous extension of any fibroids. And this was the laparoscopic view of the fibroids. This is the MRI where you can see multiple fibroids are there. If you see only one section, there were only 4 or 5 fibroids seen. When you see the sagittal section, there were multiple fibroids. And this also helps us when we remove the fibroid, so that we can see how many we have removed. Seedling fibroids still we can leave, but the major fibroids should not be left behind because they can again interfere with that. You can see a posterior large subserous fibroid is also there, which was down in the pouch of Douglas. And when you see the initial view, it looks the uterus is not very big. When we elevated it, the uterus was quite big and the largest fibroid was around 8 by 10 centimeter. So there are 4 major steps of any myomectomy. All of us know we start with the port placement. If the uterus is big, I go supraumbilical, and this was a 4-port laparoscopic myomectomy, 10 millimeter supraumbilical, 2 left lateral and 1 right lateral. The 2 left lateral ports I usually use for suturing. So incisions are given on the fibroids, and try to give incisions and take out the maximum fibroids from a single incision. So we use myoma spiral for the traction, and vaginally we give counter traction for easy removal or enucleation of the fibroids. Then these fibroids, as you can see in this, from this incision, we will be removing 3 or 4 fibroids. All the myoma beds, we should make sure that there is not too much of bleeding. So as a hemostatic agent, initially we use vasopressin. 10 units in 100 ml is the recommended. We use 10 unit in 300 to 400 ml of saline, so that works for a hydrodissection as well. Now here you can see that I have tagged all the fibroids in a thread so that I don't lose them. So I removed 5 of the fibroids. I made a necklace of them and just kept it on the anti-abdominal wall with a needle. And then I'll go for other fibroids so that I don't lose those smaller fibroids. Now this was the biggest fibroid which we removed. The steps are same, the principles are same. After this, we removed another 5 to 6 fibroids, and they were also again tucked into the same needle. I usually use a straight needle, but it's the surgeon preference. You can use a curved needle also. A straight needle is easy to insert and easy to take out. So I find it very easy when I work with the anterior abdominal wall. I can just tuck this needle in the anterior abdominal wall and it works very well. So these are the fibroids. You can see a lot of fibroids are there. And other than the biggest fibroid, we have made a necklace of all the fibroids so that we don't lose the smaller ones. Because even a single 1 centimeter or 2 centimeter fibroid, after removing, you lose it. It's like your work and efforts go off. You just keep looking for it and then you get tense. So these are the fibroids. We have just kept it here. Now we will continue with our suturing. I'm a little bit forwarding because Dr. Niranjan wants me to finish in 5 minutes. So suturing, we use barb suture, 2-layer suturing. The main purpose of suturing is approximation and hemostasis. So all the myoma beds are sutured in 2 layers so that we can give her a good uterus and she can bear the pregnancy once the IVF is done. This patient was planned for IVF, but because of corona, she could not come. I think my screen got stuck. Yeah. So continuous interlocking sutures you can give, and proper hemostasis is more important. Removal of excess blood, removal of excess tissue also is important. The redundant capsular tissue can also be removed. I usually remove them with the fibroids. Now this was the uterus we could give her after suturing. And that now looks like a uterus. Her tubes and ovaries were good. And hopefully she conceives. These were the fibroids. And the final step for any myomectomy is retrieval of a specimen. Now morcellator fell into a lot of controversy. We are still using morcellator. The upper left lateral port we usually convert to morcellation port. These were the 15 fibroids which we removed. You can see here the biggest fibroid and 1 fibroid we found during suturing. So that was not here in the string. And the others 13 fibroids are in the string. So upper left lateral port we convert to morcellation port and we do morcellation. We take patient consent for in-bag morcellation or without bag morcellation. We explain them everything. So it all depends on the provider, service provider and the patient with what agreement you have with the patient. Usually once you cut the fibroid, I think insult is done. So it is not to prevention of leiomyosarcoma always. But yes, when you use fibroid, the residual myoma's tissue or small fragments, you don't keep searching for them. That is one advantage I find. Otherwise, I find both procedures equally, they are equally efficient, and whichever surgeon's comfort, they can opt for it. And then when we morcellate it, the biggest fibroid we morcellated, and then I'll remove the other end of the thread, and one by one fibroid I'll take into the morcellator and keep morcellating them. Yeah. So one by one we remove from the string so that we don't lose them, and it's a very quick and easy procedure. Just 2 minutes. Just 2 minutes, Dr. Niranjan, I think that's...
Yes. Madam, please take your time. It's okay.
Yeah, and morcellator port is around 15 millimeters. So we make sure that we close the morcellator port with a port closure needle. And for these myomectomies where multiple fibroids are removed, we usually put a small drain as well, because chances of bleeding are there, so that we can monitor her well. And we close the port with 2 sutures by using 10 vicryl. So laparoscopic myomectomy is feasible for any number or size of fibroids if expertise is available, proper counseling of patient regarding possibility of open myomectomy. Also, we should explain the use of electric morcellator or in-bag morcellation in detail, and we should take their proper consent. List of hysterectomy should be explained clearly, and a prerequisite is that suturing is must, and a surgeon should be well expert in suturing.
Thank you.
Thank you.
Thank you, Dr. Vimi Vindra. You have done an exceptional job, and we can see the numbers, 15 of them in one go, and you have attached to the string laparoscopic myomectomy for multiple fibroids. Anyone would like to ask any questions to Madam related to her technique?
Yes. I want to make a comment that yes, multiple myomectomy for multiple fibroids is really a challenging situation, and the most important thing is that we don't miss any fibroid inside. Otherwise, after a couple of months, a patient comes with the ultrasound saying that, Madam, you have left this fibroid inside. So a pre-operative mapping is a must. And Dr. Vimi, I want to ask you whether you do or prefer doing ultrasound intraoperative to see whether any fibroid is left or not?
Intraoperative.
Hello?
Intraoperative, ma'am?
Yeah, intraoperative ultrasound. Whether any fibroid is
we do tell them, and if there can be seedling fibroids which can be left behind. So if you do a scan later, you may find very, very small fibroids. So don't get anxious with that. And very small fibroids, if we keep cutting on the uterus, it might weaken the uterus. So we do counsel them. The big fibroids, yes, we make sure with our tactile sensation, which is lacking in laparoscopy, but with the instruments, whatever we can feel, we try to remove them. And usually, I think anything more than 1.5 to 2 centimeter is not missed.
Dr. Vindra, I have a question. You were saying that this patient has to be taken up for IVF. So how much time will you give her before you take her up for IVF?
Usually 4 months, ma'am. 4 months minimum.
Surgery, Dr. Vimi, very interesting. So my question is, have you removed all these 14 fibroids through the same incision? Because most of the times when you have multiple myomas, they are anterior wall, posterior wall and intramural. So through one incision only, you could manage to take them all out without opening the cavity?
We did not open the cavity in this case. Posteriorly, we gave 1 incision. Through that, we removed 4 or 5 fibroids. Anteriorly, there were given 2 incisions because we were not able to approach the other fibroid. But when we were suturing, we made it 1 incision. Okay. Because there was very little gap left between the 2 incisions. And they were all outside the cavity. So nothing happened to the cavity.
one more question, like remove after, incising the fibroids, you take some time to put them in a string together, all 14 of them. Do you think that it reduces the effect of the vasopressin in the meanwhile when we are trying
if you have noticed, I used vasopressin 2 or 3 times. First, I remove 5 fibroids, I string them, I used vasopressin again. I usually mix vasopressin 10 units in 400 ml of saline. So it will be there, and I keep informing my anesthetist. If I want to use little more, I can, because I use 2 diluted. I use that.
A very good dilution. Even I am very careful. Like it's more of hydrodissection rather than.
And vasopressin, very minimal amount also gives you that much of hemostatic effect, so that you can just enucleate the fibroid. And by the time you do suturing, it's done. So I used vasopressin solution for 2 to 3 times for this case.
Interesting. Yes.
Thank you. Thank you.
Thank you. Thank you so much. Thank you so much. Now I call upon Dr. Neelam Mishra.
Yes.
Please share her slides. Welcome, madam.
Namaskar.
Namaskar. Very senior person, senior member of IAGE, Kanpur, resident of Kanpur Society.
So good evening, everybody. Thank you, our seniors and Dr. Niranjan for giving me chance to speak on this rare subject, heterotopic pregnancy. Spontaneous heterotopic pregnancy is a rare clinical and potentially dangerous condition, and it is defined as a presence of multiple gestation, with one being present in the uterine cavity and the other outside the uterus, commonly in the fallopian tube and uncommonly in the cervix or the ovary. The first reported case is 1708 on an autopsy finding. Its etiology being the pelvic inflammatory disease or previous tubal surgery, ovarian stimulation, and artificial reproductive techniques. In natural cycle, the heterotopic pregnancy is rare. It is around 1 in 30,000 pregnancy, while in assisted reproductive technique, the incidence increases from 1 in 100 to 1 in 500. Spontaneous triplet heterotopic pregnancy has also been reported, 1 in each tube with the pregnancy in the uterus. 70% of these pregnancies were diagnosed between 5 to 8 weeks of gestation, 20% between 9 to 10 weeks, and 10% after the 11 weeks. Patient may have not any symptom, and if this at all these symptoms are, they may be present as a abdominal mild or abdominal cramps, little bit of vaginal bleeding, pain in the lower abdomen, dizziness, fainting, bloating, nausea, and vomiting. So diagnosis is done by the beta HCG levels are usually higher for the period of gestation. This is for the one diagnostic point, and the most important is the advances in the transvaginal sonography, which help a lot in the early diagnosis of the heterotopic pregnancy, as has proven to be an invaluable tool in the diagnosis. But its sensitivity is 56% at 5 to 6 weeks, and if the pregnancy is more than 6 weeks, the presence of cardiac activity confirms the diagnosis. Tubal ring was present in 68% of cases of ectopic pregnancy in which tube has not been ruptured. Even with the TBS, adnexal sac can be mistaken for the hemorrhagic corpus luteum, ovarian cyst, and especially in the hyperstimulated ovary. Hemoperitoneum, hematosalpinx, and fluid in the pouch of Douglas, and the symptoms from the pelvic irritations are there. Its identification in the ultrasound is much more difficult with the presence when there is a presence of large hemoperitoneum because of the ruptured heterotopic pregnancy. The treatment, this is a rare condition in natural cycle, and because it is usually because of the ART techniques, so the patient after the ART, so they have a strong desire to preserve the viable intrauterine pregnancy. So the key point of the treatment is to preserve the viable intrauterine pregnancy and resolve the ectopic pregnancy. And this makes the treatment of heterotopic pregnancy very difficult and challenging. So this condition is very rare in natural cycle. However, with the increased use of the assisted conception technique, doctor must be alert to fact that the confirming an intrauterine clinically by ultrasound does not exclude a coexisting ectopic pregnancy. And identification of intrauterine pregnancy can divert attention from the possibility of concurrent ectopic pregnancy. After diagnosis, the ectopic component in case of rupture is always treated by surgically, and intrauterine pregnancy is expected to continue normal. So when the ectopic pregnancy was detected early and it was unruptured, the treatment option include abdominal sonography guided transvaginal aspiration of the ectopic, and the next is the surgical treatment. This paper was published in the China. There was experience from Tertiary Medical Center by Jin Bio and Ling Ji and Jin Bio, Yang and Gang New. They have done an aspiration of the ectopic sac from the transvaginal route through abdominal guided ultrasound. And after aspiration, they sometime to kill the embryo, they have used hypertonic saline also. And they in the early pregnancy, when it is only 4 to 5 weeks, it was effective, and there was no need for laparoscopy in these cases. But only thing, this can helpful only in the cases when the ectopic is present in the ampullary end, not in the cornual or ischemic site. And these patients require repeated follow-up and transvaginal ultrasound if there is a size is ectopic is not increasing, or if there is any rupture. So they note a very close follow-up this patient. These are the few papers were published by these people, and they found that it was very helpful, especially if the pregnancy was early and it was in the ampullary end. The laparoscope approach is definitely technically feasible for both cases without disrupting the course of intrauterine pregnancy. Even in ruptured heterotropic pregnancy, laparoscopic technique is the best. So here is a case presentation of 22-year-old female diagnosed as a primary infertility, underwent controlled ovarian hyperstimulation with the help of exogenous gonadotropins hormone. She presented to the hospital with the emergency department at 5 weeks of gestation, complaining of lower abdominal pain, abdominal distension, and nausea. The transvaginal ultrasound showed a small intrauterine gestational sac with no fetal pole consistent with the 5 weeks of gestation. The right ovary was enlarged and measured 4 into 3.6 centimeter, showing a small cyst, and the left ovary measured 3 into 2.6 centimeter with the mild fluid in the pouch of Douglas, hence leading to the diagnosis of mild OHS with the early pregnancy. The supportive treatment for OHS was given and she was discharged with the instruction to return for review in the early pregnancy assessment after 2 weeks. The patient presented at 9 weeks of gestation with the complaint of lower abdominal pain, mainly on the left side. Vaginal ultrasound showed a single viable intrauterine pregnancy with a crown-up length consistent with the 9 weeks of gestation, and the right ovary enlarged, measuring 5.3 into 3.3 centimeter with a small cyst, and evidence of the left adnexal mass measuring about 6.6 centimeter, containing a gestational sac of approximately 8 weeks, suggestive of left tubal ectopic pregnancy. Her transvaginal, this is all the hematological investigation and biochemistry was done. The beta HCG was at 5 weeks about 1800, at 9 weeks it was about 2800, and all the midstream urine and high vaginal swab was done. The patient received a supportive treatment for mild OHS in early pregnancy. At 9 weeks when she was diagnosed, a laparoscopy was done and ectopic pregnancy was removed successfully by doing a self-injectomy. Her pregnancy continued till term, and her cesarean section was done at term for the cesarean section. Of course, after all this procedure, she required some tocolytic drugs and progesterone support. Here is a video. This is a left-sided ectopic pregnancy. And is a case of heterotropic pregnancy with an intrauterine pregnancy of 9 weeks and pregnancy in the left fallopian tube, which is almost 9 weeks size. I have used bipolar forceps and scissors step by step by doing a bipolar coagulation and cutting by scissors. The self-injectomy was done. Because of the blood, the field is little dark, and we keep a little away the optic field. You can see the small fetus lying inside. The ectopic product, they were removed in the endo bag, retrieved, and it is removed completely. after doing this procedure, a generous peritoneal lavage should be done, and patient is given tocolytic drugs and short support. Thank you. Thank you.
Nice presentation, Dr. Neelam. And
Thank you.
nowadays with the IVF, we are getting more and more heterotopic pregnancies. And it's really takes much effort to diagnose these conditions, because once we see pregnancy inside uterus, we don't really bother to see it.
Yeah,
but
we get so happy, we don't bother about the maybe there's something, because normally people they put 2 embryos, normally 1 embryo transfer is less. So
like you said, since initially she was suspected like an hyperstimulated patient, and with OHSS we get pregnancy, then we are very happy and send the patient home. So I think it's a good thing that this kind of case you have presented. It's very nice. That we should always
she came, actually we called her after 2 weeks for follow, but she turned up after 4 weeks. That is a problem. Yeah. It's very difficult to follow this patient.
She was a lucky patient actually.
And lastly, she came up with that source. That is the most important. Thank you.
Thank you, Dr. Neelam. Thank you so much. Now we go to the next presenter. We have with us next presenter, Dr. Aarti Luthra, madam. Okay, Renu Singh, sorry.
You want me to share the screen, Dr. Niranjan?
No, madam. Renu Singh has already shared. I'm sorry.
Okay, okay, great.
Yes, please continue, Dr. Renu. Your please unmute. Please unmute your mic.
Good evening, everyone. I'm Dr. Renu Singh Gehlot from Kanpur. Thank you, IAGE, for giving me this opportunity. And I must extend my heartfelt gratitude to all the patrons and the stalwarts of endoscopy, from whom I have learned and have reached up to this level and serving my patients. So she is a case of infertility with a big lump in the abdomen, and on transvaginal sonography we could see a big intramural myoma as well as a broad ligament myoma. Here the principles of myomectomy have been nicely covered by Dr. Bimmi. So vasopressin 10 units in 100 ml of normal saline was diluted, approximately 300 to 400 ml was injected. It gave this very nice thing. Otherwise we can definitely go ahead with uterine artery ligation, but we do avoid them in patients with infertility. So traction and counter traction is a very basic component in all sorts of myomectomy procedures, and equidissection not only it helps in giving us the plane, it forms a layer, very beautiful plane between the endometrium as well as the myoma. So the endometrium is very nicely saved in such cases. So we decided to tackle one myoma at a time. So once this myomectomy was done, barb suture was done, and with the help of barb, taking care not to take any bite from the endometrium, otherwise it does lead to adhesion within the endometrial cavity. So we have seen 1 or 2 cases where the barb stayed even for 6 months, even if a single stitch was there, and it leads to iatrogenic septa or adhesions within the endometrial cavity. Then suturing in multiple layer is the key. Non-use of any cautery, I think, is very, very important as far as the infertile patients are concerned in long run. It avoids any hematoma formation. It avoids scar dehiscence. So important is to prevent any dead space formation, whether you use a barb, whether you use a bicryl, whether you use a single layer or a double layer. It's the choice of a surgeon. So this particular myoma bed was nicely sutured, first with the bar, and finally the last layer was being taken. Now the attention is being paid to the broad ligament. The right broad ligament myoma was seen. With the broad ligament, there are three important points to be taken into consideration. Whether it is a true broad ligament myoma or it is a false broad ligament myoma. So the true one will appear from the mesometrium or the round ligament or the utero-ovarian ligament. And the false one will appear from the uterus and will definitely have a stalk attached to the uterus. So while considering any broad ligament myomectomy, we have to take into consideration the fallopian tube, the ovarian ligament, the round ligament, as well as the course of ureter. Usually these myomas, they do very well with the equidissection. They are not very much vascular as such, but often we have seen in our case series of 23 patients of broad ligament myomectomy, these myomas are very hard. Probably they are there in the cavity for long, and while we are giving the incisions, even if we are using little amount of cautery as and when required, we can over here because this is definitely not going to affect a patient of infertility. But in the bed of myoma, we have to take into consideration the course of ureter. Any confusion while going ahead with the myomectomy with any sort of confusion, ureterolysis should be the key. Retroperitoneal dissection and ureterolysis should be done prior to broad ligament myoma if the course of ureter is not properly visualized or if there is any confusion. So there was again a very small myoma which was removed and suturing was being done. Next, the very important step of broad ligament myomectomy is to observe the base of myoma. Over here, the uterine artery, the ureter course, the round ligament, and this was the base of myoma was nicely been observed. The course of ureter was being completely analyzed from the sacral promontory till the base, and though there was a little bleeding of approximately 10 to 15 ml, anyhow we avoided using any sort of cautery in this particular case so as to avoid any future complications. A simple vicryl number 1 was used here and the base was sutured. It was just to avoid future adhesions. And all the time while taking sutures, it was important to take into consideration the course of ureter, the uterine artery, and little suture, one or two sutures were definitely taken from the round ligament so as to plicate the round ligament. And then in the end, it was also very important, as she was an infertile patient, to take care of the fallopian tube. Because often in such cases, the fallopian tube get flattened, and while taking the sutures or while giving incisions or while cauterizing, there are high chances of giving some damage to the fallopian tube. And finally, a nice saline wash has been done in this patient. We do believe in taking out myomas in bag. It actually saves times. It gives a very clean pelvic cavity. It gives you peace of mind. It prevents chances of leiomyomatis uteri later on. It's actually a simple procedure, and just by extra 10 to 15 minutes, it gives us a lot of benefits. And definitely it prevents nowadays from litigation also. So both the myomas were put in the MorSafe bag. Lineator MorSafe, morcellator was used here. Both the myomas were morcellated in the bag. Approximately 1.2 kg were the bits of morcellation. And one very important finding I'm really happy to share here. This particular patient conceived on her own just after 5 months of the surgery, and later on she delivered a 2.8 kg baby by cesarean section. Thank you so much, and thank you all.
Very beautiful video, and by Dr. Renu. I must applaud for this. It was really well done.
Thanks a lot.
Any questions from anybody?
Nice presentation.
Thank you, ma'am. Thanks a lot. Any questions, ma'am? I'll be happy to answer.
I think you did an excellent job, Renu. Yeah.
Thank you so much, ma'am.
Although what we do sometimes is that we don't reperitonize, we can just take a few, very loosely we reperitonize. So even then later on when we do a relook or we have done some cesareans, so it is not, there is no need actually. If you feel that there will be tubal distortions, you can even take only interrupted a few bites and just leave it like that.
Definitely,
in the broad ligament, in the broad ligament, because actually
then you can leave it like that. Otherwise, if there is oozing, like Renu's case,
only if there is oozing.
If you leave it open, there will be a collection of blood. It is not advisable. And I think after such a clean dissection, there's no need for putting any drainage and all. Once you suture it properly, there is no need. But we can leave open in cases of broad ligament fiber.
Because if there is infertility.
If there is no,
right.
Congratulations, very nice. Do you ever leave the drain when they are very large myomas?
Ma'am, yes, we do. Sometimes we have seen if we are taking a little longer time and we do see some little amount of oozing from the myoma bed or some sort of suturing, anything. I think leaving drain hardly it's of any problem.
And you already have
it prevents adhesion formation. In fact, it prevents adhesion.
Yeah, ma'am.
Sometimes vasopressin goes away and then it starts oozing from suture line. So it is better to leave.
Sure, ma'am. We can. For that, for adhesion prevention, I definitely believe by putting 500 to 700 of normal saline and putting 1 ampule of Dexona in that. So it is there in all my cases of laparoscopy, except if the peritoneum appears to be of tubercular or Cox abdomen. Otherwise, whether it is a case of TLH or any surgery. So it really gives a very good result. And post-operatively also, we can discharge our patient just after 1 liter of fluid.
What about interseed?
Ma'am, I think if we have done a good job, suturing is nice. There are hardly any raw areas. Ma'am, as we know, our patients are really not very affording, like they are not paying us in lakhs. And I don't find any need. So if a simple normal saline can do a good job, why to unnecessary put? So we have to choose, like either we can use an interseed, we can use a normal saline or whatever.
In like a posterior wall fibroid or sometime in fundal fibroid to prevent adhesions.
Yeah.
Thank you. Thank you, madam. Thank you so much now, Dr. Renu. Wonderful discussion. Thank you, Neelam, madam.
Thank you so much.
I request Dr. Aarti Luthra, madam, to please start her presentation. We are eagerly waiting. Madam is waiting. Thank you.
Thank you, Dr. Niranjan. First of all, I must congratulate you for organizing lovely workshops, webinars all through. And thank you for giving us this opportunity to share our skills and learn new tips from all the stalwarts. So, yeah, I'm going to share my screen very soon. Is it, is my screen visible?
No.
No. No? Okay. 1 second. Now? Yeah, 1 second. Share screen and optimize and 1 second. Is it visible now?
Yeah.
Okay.
Yes, it is visible.
So I'm going to be quick. I was going to discuss about fertility enhancing tubal surgery, but when I was going through my videos, I realized, like very few cases of tubal block can be enhanced by doing laparoscopic surgery, because as we all know, tubal block is responsible for 30% of cases of infertility, and we can do salpingo-ovariolysis. And if the distal tubal disease is because of fimbrial block, we can remove it. Or if there is proximal tubal cannulation, we can do hysteroscopic cannulation for proximal block, or we can do post-ligation recanalization. But most of the times, if we see tubal block on other modes of tubal assessment like HSG, the block is bad, and maybe 50% of these cases they land up in being referred for IVF only. So what all we can do for tubal disease and tubal factors of infertility by endoscopically? The simplest is, if we are lucky, would be fimbriolysis. Lot of times it's a bad HSG, the fimbria badly blocked, and if we do fimbrio-ovariolysis, we can release the fimbria, make them free, and if we are lucky, we can get a free spill of the dye if the proximal tube is not occluded and the inner side of the tube is healthy. Like this patient had a bad HSG film, but when we took her for endoscopy, we managed to get spill, and she conceived 2 months after the surgery. But sometimes, you get block on HSG, and when you go inside, this is an old video, but this is a classic case of Cox abdomen. That's why I wanted to share it. You can see small tubercles in these Fitzhugh-Curtis adhesions, and the liver is practically hanging with the undersurface of diaphragm. And when you see the pelvis, both the tubes are, in the net of adhesions, and she had hydrosalpinx also. So we tried to release the adhesions, but we knew that these tubes are unhealthy. As you can see that the tube is badly dilated also, and there are adhesions, and these tubes had unhealthy fimbrial end also. So this patient was advised IVF later. And as you would see, even near the left tube, you would be able to see caseous material in this patient, although her gene expert test was negative. So these cases, we are very clear that if we have to, suggest them a good outcome, they have to be referred for IVF, which can give them a better result. Now, some of the cases which give good prognosis are tubal recanalization. This is, one of the indications for tubal surgery, which can really give us good prognosis if we are lucky to have a longer distal segment of the tubes. This video which I am sharing is of tubal recanalization, and this patient had both the distal length of more than 4 centimeters, and they were healthy fimbriae. So what we did, we excised the segment, and by putting in the catheter, we checked the patency from both the sides, and using 6-0 sutures, we did the tubal recanalization, and she had a good result post-surgery, and then she had 2 babies after undergoing the procedure. The best advantage of tubal surgery is, like, the patient, doesn't have to go for IVF each cycle and each time she wants to plan a baby, number one. And number two, it's a relatively economic, procedure as compared to undergoing IVF cycles again and again. And, this is another case which I would call that we can conserve a tube. A lot of times, if you have ectopic, you diagnose it early, and if the patient is having a healthy looking fimbria end and there is no active bleeding, we can try to save this tube also by doing a good, clear, linear salpingostomy, and we can remove the POCs and let the tube heal, because otherwise rest of the, pelvis looks clean and healthy, and the other tube although looks normal, but we tried to save the tube and we did linear salpingostomy in this case. And there are a lot of other indications like history of pelvic peritonitis or history of previous surgery which can give unhealthy tubes. This is a case of bilateral large endometrioma, which I would not like to share, but these cases, the tubes are normal, but they are also not normal. Why? Because the tubal anatomy is distorted, the surrounding factors are bad. So one has to, remove the endometrioma to improve the ovarian functions. And once the anatomy is restored, and if the lady starts ovulating, we can get a good fertility outcome in these cases. And there are many videos, but I think we are already, getting late. I would like to invite questions before Dr. Chavan tells me, that we are getting late. So, any questions, please, most welcome to ask me, because there are videos, lots of them, but, have I stopped sharing the screen? 1 second. Escape. Yes.
Nice presentation, Dr. Aarti.
Thank you.
And nowadays, this tubal surgery are not much in vogue because we are more inclined towards IVF. And I would say that cornual blockage are more have good results when we open for spontaneous pregnancies rather than fimbrial things. And first of all, we have also should look upon the age and ovarian reserve of the patient, and then we should embark on tubal surgery.
You are right, but this patient for whom we did she was 37 years, and a lot of elderly women, they lost their babies in Kedarnath tragedy, if you remember. And they come from far away, and they just afford IVF because they are poor people, lost 2 of their sons, and they're very keen, doctor, you just unite the tubes. And she was lucky, like she was,
tuboplasty is good.
And she had 2 babies. So there are indications, like depending on the patient types, when the patient is just not keen for IVF procedure, they can't stay with you for very long, they just can't come back to you again. So for those cases, I think we have to reserve it.
Resterilization has a good outcome, but in other disease tubes, if you open, then they end up in
absolutely you have to see, because if it is simple tubulation done to for contraceptive indications, most of these patients would have healthy tubes. Yeah.
One thing, doctor, I want to ask you, cut the tube ends with the monopolar. Don't you think you should cut with the scissor for better healing of the 2 ends after putting in the mesosalpinx?
What we had cut it with on very low cautery settings. Why? Because if you cut it with the scissors, it gives a sharp cut, but lot of times, the artery which is near the mesosalpinx, it bleeds a lot, and you don't want to touch the cautery there also, because if you touch the cautery, and maybe because I clipped the video, what we do, we give dilute vasopressin in the mesosalpinx so that it gets avascular, and on very low pressure setting with just one go, because if you give 2 snips, the edges of the tube get irregular, and then the approximation is not very good. But it's individual surgeon's choice. But low pressure, it gives a clean, very sharp cut so that we can stitch it properly.
But with scissors, healing the upper layer, it retracts very nicely. So they are a very clear-cut layer you can see in the fallopian tubes. You can leave the mucosa, you can take the outer layer only like that. I don't know, it is your preference. Maybe this is better.
Yeah, with cautery also, the inner layer, mostly it pops out and the outer serosa retracts so that you can give stitches leaving the serosa alone.
But after putting vasopressin, usually bleeding, it is not much bleeding. If 1 or 2 points, you can coagulate. Otherwise, putting vasopressin in the mesosalpinx, I think it works well. Okay.
What are Dr. Amit's views? Dr. Amit, so good to see you after so long. Yeah.
Same here.
Yeah,
ma'am. I put vasopressin in the mesosalpinx.
Yeah.
And then I cut the tube and I cut it with usually cut it with a sharp incision.
Yeah.
So as ma'am said, the serosa of the tube, it retracts by itself. So you get a good thick pedicle of the tube muscularis to do the suturing. So I think I usually do a sharp dissection. And I know Dr. Sanjay Patil, he's in favor of doing it with the monopolar, and they say if you do it with the pure cutting current, you don't damage the mucosa of the tubes, and it is as good as doing with the scissors. So since I put a lot of saline vasopressin in the mesosalpinx, and you can delineate the vessels very sharply, so you don't need to injure the vessel, and usually they don't bleed. That is my experience. And nice presentation, ma'am. Nice presentation,
nice
everyone.
Yeah, very nice,
Yeah.
Dr. Aarti. It was very nice.
Videos were very nice.
Videos were very nice. And
few of them were more, but because we also don't do recanalization regularly, but when you talk about tubal factors, most of the videos were showing healthy, and half of them we were either endoscopically, because I think it should be tubal assessment endoscopically. Yeah.
so, but
Thank you so much, all of you. It was a wonderful presentation by Aarti and Neelam, even Renu, Madam, Vimi, and Jyoti Mishra. And I would like to propose now that Dr. Tandon sir give the vote of thanks. We have already gone beyond 2. We are nearing 3 hours.
Yeah.
Absolutely.
So I'm extremely thankful, first of all, to Dr. Niranjan Chauhan for organizing this webinar and taking the initiative and organizing it so well. And I'm thankful to the senior patrons who graced the occasion with their presence: Dr. Raj Baveja, Dr. Chandravati ma'am, Dr. Jadi Malhotra ma'am, Dr. Naren Malhotra sir, and Dr. Ragni Singh, Dr. Anupam Gupta ma'am, and to our chairpersons, Dr. Neelam Mori ma'am. And I am also thankful to Kiran Pandey ma'am for coming and attending and being present till the end, and Sunita Karim ma'am, and to other senior people who are present here, and also very thankful to the presenters of the video session, and Dr. Renu Gehlot, and Dr. Vimi Bindra, and Dr. Aarti Luthra ma'am, and Neelam Mishra ma'am. Thank you so much for coming and giving your presentations. And we will try to organize more CMEs in the future, webinars in the future, so that we can share more knowledge for and bring this UP chapter of. Especially, I forgot to thank Dr. Nutan Jain ma'am for giving a wonderful talk on this pectopexy, wall prolapse. Thank you, everybody, for coming.
Thank you, everyone.
Thank you,
And please,
everyone.
the IAGE elections are coming up. Please vote for me as a managing committee member.
Yes, ma'am.
I'm
Yes, sure.
contesting for that.
Yes, ma'am.
Thank you.
Thank you,
And I
Dr.
would also
Niranjan.
request you to please
Thank you
vote
so
for
much.
me for the treasurer's post.
Sure.
Sure.
And I need your blessings
You
for.
will win. You are already the winner.
Thank you, madam. Thank you.